Both of you scrub. Need scrub. And disposable వాళ్ళందరికీ ఈ గౌన్స్ ఓన్లీ నీ గౌన్ మనకి రాదు ఉన్నాయి కదా అన్ని తీసేసి నీ కూడా డిస్క్రైబ్ కావాలి నీ అవసరం లేదు ఆమె ఉంటుంది డోంట్ నీడ్ కదా వాళ్ళని ఎవరైనా స్క్రబ్ చేస్తారు వీళ్ళు లేకపోతే అమ్మాయి స్క్రబ్ చేసుకుంటాం నీ గౌన్ చేంజ్ చేసుకోవాలి ఆ గౌన్ మనకి రాదు నీవు దాంట్లో వస్తావు టీవీలో వస్తావు Arvind, are we live? Yeah, that's the one. Okay. Can we make it bigger? Can we make it bigger, that one? ఇగో నాది ఎక్కడ ఉంది ఇగో నీవి ఇక్కడే ఉండవు ఇది నీవు కోఆర్డినేట్ చేయి నెక్స్ట్ దానికి నీవు రా కోఆర్డినేట్ చేస్తా కొంచెం చూసారు కదా Can you make, oh, very good. That's what. Can you hear me? Where is the camera? This camera.
Yes, sir, we can hear you.
You can hear, okay.
Yes, sir.
So we are about to start.
Okay.
I want to, so you start off, where is Ravi? You start off introduction. I can't hear you.
Yes, sir.
You start off.
Yeah.
Once you start off and hand over to me, then I'll take over. Okay?
Sure, sir. I'm here. I will we'll start the introduction and then we'll give it.
We are live. Ravi, we are live.
Yes, sir. No, not yet live, sir. We are about to go live.
Okay, then before in that case, just hold on a minute. We plan.
Okay.
So what you do is introduction.
Yes,
You start. Otherwise, shall I send Pranit there to moderate?
yes.
Go and moderate. Well, అక్కడ వెళ్ళు వాళ్ళు రాలేదంటే ఇంకా నేను వెళ్ళి moderate చెప్పు Pranit is coming there, both of you moderate. And so tell me the first session, what is the plan? So introduction, how long are you going to take the introduction?
5 minutes introduction, sir. And
5 minutes. Can you show some visuals, yesterday visuals in between?
we'll try, sir. We'll talk to the audiovisual guys and show some videos. Yes,
Yeah, just visual. I forgot to tell you last night. Maybe a few visual about our walkathon in between.
Sure, sir. Sure.
Okay, so in between when I want to say we have a gap in between, so you have to show get more as many clips as possible.
Yes.
So start off. You start introduction. What is the Ravi? You speak first. Okay, you start off, and these the people will just say one word. Then they will take over.
Sure, sir.
Then again you come in and introduce the surgery. Okay,
Yes. Sure,
Okay.
sir. Sure.
go on. We can go live now.
Sure, sir. Sure. We'll do that.
ఇది పైకి రావాలి అన్నెసరీస్ ఉండండి డోంట్ మూవ్ స్టే దేర్ ఓకే అండ్ దిస్ ఏరియా నోబడి షుడ్ బ్లాక్ ఓకే నువ్వు ఉండు అన్న ఇది పైకి పెట్టాలి పైకి సో వన్ కెమెరా ఫ్రమ్ ది టాప్ యు నో all about it, okay? And one camera, probably. I'll be standing there, so you focus on me. That doesn't matter.
Sir, this is Ravi again.
Our PGs to start off. Introduction, including introduction. Can you hear me? Okay, go on.
A very good morning to all of you. We welcome everyone present here in the auditorium and doctors joining us live on OrthoTV for live surgeries and CME program on the occasion of World Arthritis Day.
Good morning, everyone. This is Ravi Teja. We are very glad to have you online and as well as the podium audience here. We are going with the live surgery first by Dr. KJ Reddy sir. So we would like to have our moderators, Dr. KLJ Rao sir and Dr. Anjaneyal sir, to come and please sit on the stage so that we can very soon start the live surgery. Thank you.
Yeah. My. Hello.
So we have Dr. KLJ Rao sir and Dr. Anjaneyal sir on the stage. Sir, Dr. KJ Reddy sir, can we start discussing about the case before starting the surgery?
Sure. Yeah. So can we have the X-rays? Can you show the X-rays on the X-ray board? We will focus on the X-ray. Jairam, you can tell brief. Sorry, what is the name? Age of the patient? Age 65 years. How long? Yeah, she is a 65-year-old lady having a pain in both knees for the last 4-5 years, and recently got worse, unable to walk. And those are the X-rays, as you can see. There is no significant deformity, but there is a significant arthritis, especially on the right side. And she wants knee replacement. As you know, nowadays, patients are very informative. They know all about the treatment, their diagnosis and treatment, and they go around taking many opinions. So she decided to have surgery. So we planned to do bilateral knee replacement. And as you know, in India, bilateral osteoarthritis is very common, and most of them both are quite significant. So majority, if their patient are fit, I do simultaneous bilateral TKR, same sitting, sometimes with a gap of 1 day. If we can't do in the same sitting or gap of 1 day, probably I will give a gap of 6 weeks, minimum 6 weeks. I won't do in between because, as we know, the incidence of DVT, other things are high. So those are the X-rays. Just can I have the camera on the draping? I just want to show you the draping. If we can go back, zoom out. So it's very, very important because people, what happens is positioning and draping is very, very important. Unless you have good assistants or your colleagues like me, you should position yourself and you should drape yourself. So when you position, can you this camera? So I use a thigh support, go back. Now zoom out, not go back, zoom out, out, completely. I want the entire leg to be seen. Out, more out. I want that camera. Yeah, you can see, close, little close. I am not holding it. This is the thigh support. This is the foot support. So when the heel is on the sandbag or foot support, it should be 90 degrees. The knee should be 90 degrees. When you put the foot, it should go more than 90 degrees, maybe 100, 110 degrees. That should be your positioning. Positioning is very, very important because once you start, the position is not proper, you struggle throughout the operation. Next is draping. And nowadays, of course, draping has become very comfortable because extremity drape has come. As you can see, this one is a bilateral extremity drape. Put few drapes before and use bilateral extremity drape. And upside, so go around, and the leg, you can use a cling film or use a small towel and bandage. And I use a H mark to exsanguinate unless there is a contraindication. So we're going to exsanguinate. Yeah. And I forgot to introduce my team. This is anesthetist. Can you show camera to Dr. You can take, allow to take a mask a little bit. 1 minute, 1 second.
Implant.
Our anesthetist. Name, block name. Huh? Ayatollah, Dr. Ayatollah has been with us. He's a professor of orthopedics, but not orthopedics, anesthesia. He's been trained with us and he's been with us for a very long time. And his team is there. And this is Dr. Jairam. Sure, you can't take mask up. This is Dr. Jairam. He's a backbone in SVS. In case of high, but you can get tunica palsy. Okay, marking pen. Give me small knife. Come here, come close. Probably you can move little back. Can you move back? Stool కొంచెం వెనక్కి చేసుకో, no problem. Problem అయితే మనం వెనక్కి చేసుకోం కాదు కదా. Little, that's okay, that's fine. Knife, I'll just put this on. Okay. I'll just. Okay. So give me a marker. Give me a marker, some form of marker. Table down little.
Dr. KJ. Hello.
Can you? So.
Hello.
Yeah, very good. That's a good view. So mark the patella. Good morning, Dr. Jagdishwar and Dr. Anjaneyulu.
Good morning.
Welcome to the program.
Good morning, you're saying.
Dr. Anjaneyulu is there?
Yeah.
I'm here.
So,
Okay, scrub just gone. Ask them to scrub. Come close. Get me this one better in.
so what's the plan, sir? What?
Yeah. Plan is to do knee replacement.
Okay. But
There's no, see the problem, the advantage of doing orthoplasty is not many plans. You only do hip replacement and knee replacement. So, to do, because as I was saying, there is no significant deformity. That's why it doesn't much of release.
that means
Marking
soft
pen.
lesions
I'm just marking the landmarks.
right.
Probably it won't stay.
Ravi?
Yeah, go on. You wanted to ask something. So as you can see, what's important is the patella. You can see the patella. That's a patellar ligament, tibial tuberosity, and it's a midline, but not over the tibial tuberosity. Medial to tibial tuberosity. Knife. And get it. All is close. So put 2 fingers either side of the patella so that you know where is the midline, and palpate again your tibial tuberosity. So start in the midline, come down, gently deviate medial side, and you should not go down too far, because if you go too far, you damage the saphenous branch, medial branch of saphenous nerve, which will lead to numbness. Sometimes it causes dermatitis. You might have seen some of the TKR patients, if they get dermatitis around inferior part of the, or the proximal part of the tibia. And not too much of soft tissue dissection, just identify your tibial tuberosity. Okay, knife, inside knife. And in the midline, go. Can I have the top? Can you see? Jagdishwar?
Yeah. All okay, I'm able to see now. Right.
Yeah. So it's important, leave little bit of what is that? Retinaculum attached to the
Yes.
patella so that is easy to close. Straighten it up and subluxate the dislocate the patella. You don't have to do sometimes short knees, tight knees. Knife again. Forceps.
Right.
You don't have to sublux the dislocate the patella. You can do. There is a little
Just
debate about whether to dislocate or not. With robotic knees, we don't sublux or dislocate the patella. So I take the fat pad which comes in my way. You don't take entire fat pad because that supplies the blood supply to the patellar ligament. Okay, somebody take that one.
Okay, how much is the synovium to be removed or not completely?
I didn't understand.
No, the synovium, which is there thick and
No, we used to do synovectomy in the past, but
Oh,
problem with synovectomy is they bleed
all right.
and it will form more. So don't do routine synovectomy unless there is
Only fat pad.
significant synovitis.
Right. Okay.
And now I can see, can you see? That's completely eburnated bone, completely eburnated tibia as well as femur,
Okay.
and the patellofemoral joint is completely damaged. So we do not release much because there is no deformity at the ligament. There is no ligament, medial ligament or lateral ligament contractures. We only expose it, and the deformity is corrected at the level of bone in this case because passively deformity is completely correctable. And just make sure you isolate the, that's the MCL there, as you can see. Just go underneath the MCL with your periosteum so that you don't damage while you're sawing. And one more tip you can see there. Come close. That's the osteophyte, medial osteophyte. So if you cut that, take that one off, it's like equivalent to midis, and it will release the MCL as well. You can see that's the MCL there. That's white structure. Can you see, Jagdishwar?
Yeah. But,
That's the MCL.
right.
And what happens if it is close to the tibia? When you're doing tibial cut, it will damage the MCL.
Right.
So just go up to the posterior medial corner and take that off. And I don't use Langenbachs, as you can see, most of the time spikes, because Langenbachs do more harm in soft tissue.
One question, sir.
Yeah, go on.
If the medial ligament is inadvertently cut,
That's what-
Yeah.
what needs to be done?
I haven't gone that far yet, but I think thank you for reminding me. Yes, MCL is cut means it's not a nice thing to cut because then you can't do unconstrained knee. You have to do You have to do a constrained insert and repair MCL. If it's a clean cut, you can reinforce repair, primary repair. If you can't do primary repair, then you have to use a hamstring graft. But you have to use a constrained knee, in the sense constrained insert. So one more tip, can you see that's osteophyte? You can't see where is the entry point. So what I do, little osteotome, clear that part. So your entry point is clear. Take it out. And I just want to show see that is the PCL. So just anterior to the PCL in the middle, in the direction of the canal. So I just enter there, as you can see, and you enlarge and push it in. Don't dream. And this one has got, as you can see, widens it. Can you see that one? Where can you see? No. Yeah. Can you see this differential diameter? This one is small, this one is bigger. So even there is little disorientation or wrong position, it will get corrected because the rod you are going to put is this size. So it will not go into valgus varus position. That's the rod. Okay.
What reference you are taking, Dr. KJ? Hello.
The cut will be, where is it? We take 9 millimeter standard, but what happens is, just a minute, I'm just getting this. Down. Very good. Okay. So what happens? I do PS knee. So I take 1 millimeters,
Yes.
1 millimeter more. So I can see here. Can you see the cut there? Can you show me there? So 9 millimeter is standard one, but I'm taking 10 millimeter here. Can you see there? Probably from the top. Can you see that one? That's the 10.
Yeah.
9, 10, 11.
Okay.
And sometimes you can go up to 11. Probably if you're not touching properly, you can go to 11. Okay, pins.
Is it referencing anterior or posterior, this one? Hello.
Sorry.
Anterior reference or posterior reference? This is what the jig.
This is, yeah, this is a, I'll show you the referencing. This is a, before taking reference sizing, this is only distal femoral cut. Okay, and as you can see, I'll use a threaded pin because most of the time you use a smooth pin and hammer it, which will, what happens is, this is a threaded pin you can see.
Right.
So threaded pin will hold longer, it won't become loose. Careful, don't fall. Angel wing. So that is, we are taking about probably, as we know, the basics is we only replace what we take. So general guide is when we put it in the notch, you should not take too much of notch. So it is falling in place and taking about maybe 9 millimeters. So with using saw, what happens is if you use a plain pin, it will become loose and it will change the orientation. Okay, done. So I guess that's a first cut. And you run your saw again because if it is hard bone, it jumps up. So just see whether it has done or not. As you can see, taking a little more. So it's very important to run this saw second time. Otherwise, you will miss 1-2 millimeters. Again, this one only. So now, Dr. Anjaneyulu, your question. This is PFC knee. So it's anterior referencing one.
Yeah.
So before that knife, you cut the lateral meniscus anterior side so that you enter into that one. And this is also one more tip. If Sai is there, you can show this tip again. So just introduce underneath. Just make it loose. Make sure you do not struggle with the jig of sizing jig. Okay, put that one. And this camera, probably, if you come here, better, or you're in between them. Yeah, if you come in between, I think it's 90 degrees to me. Come this way. This camera, can you see? That one is completely flat.
Yes.
It should be flat. Both sides.
Right.
And behind the
Inferior.
Posterior condyles. We assume that posterior condyles not damaged in osteoarthritis. That's the referencing point. And is anterior reference. Make sure it does not notch. So now it's coming to, this is interesting. It's coming just close to the, can you see that reading? 2.5. This one from this camera. Yeah, that's a 2.5. So that's our size. Little less than 2.5, but I think you can adjust in a way that closest to the one. Yeah. So size is 2.5. That's a 3-degree external rotation, right side 3 degrees.
Okay.
This one. Okay, good. And again, threaded pin. So my size is, femur is 2.5. Generally, female population will have between 2 to 3 sizes. And make sure if you're not sure, measure the size again with the jig. I'm just putting inside. So, angel wing again. So make sure the posterior condyle you're not taking much. I'm not taking much there. And here also not taking much. And make sure you're not notching anteriorly. Can you see? Top one, top camera.
Superior.
Can you see that one? You can't. Top. Yes.
Yeah.
See, that is the just touching the anterior cortex here. So we are not notching there. So additional supportive pins with a stopper. As you can see, it has got a stopper. So it will stop and hold well. So the threaded pins with a stopper. Okay. So again, you can see this one, top one. This is piano. Can you see? That's a piano shaped. And it's flush with anterior cortex. If you do anterior or do not take proper one, there is an overstuffing of the patella. Sometimes we do for the sizing. But this is ideal. It should be flush with anterior cortex and you should not notch the anterior cortex. And as you can see, I changed the size of the blade. I use a bigger one. This is a smaller, medium sized blade for the posterior cut. Okay. And when you're cutting posterior condyles, do not go completely back. So leave within the bone resistance so that you don't damage posterior structures. Cutting the chamfers, anterior chamfer, and that is for the bone block. Take bone block. And posterior chamfer. Good. Anjaneyulu, any doubts or any questions? Not doubts.
Yeah, going smoothly.
Okay, good. Thank you.
So all these cuts can be made with one jig only, no? All.
Yeah. We don't do any freehand cuts.
Yeah.
All through jigs.
Right.
And one more trick I'll tell you, I think. So that is a posterior
Yeah.
condyle. So I have not broken completely. Just a little, bend it down. So now it's become complete.
Okay.
Withdraw osteotome little bit outside and withdraw this one.
Right.
It comes out easily. Same thing other side. You can see. There's a little osteophyte, so take osteophyte out and then this one out. Can you see the medial osteophyte there? And the lateral osteophyte. Little more is still there. I can take that one later, but hammer. Nibbler. And now this camera subluxes the tibia forward. And after a long time, probably 30 years, we had recently, while we were doing this subluxation of the tibia, probably we had a little damage to the vessel. That the first one probably should be last one. Not complete damage, but there was contusion.
Injury, yeah.
So you are very careful when you are subluxating, especially in a deformed, severe osteoarthritic knee. Now that's the lateral meniscus. Bit longer, please. Bit more. Okay.
Can you please show the popliteus tendon attachment to the lateral meniscus?
Sure. I'll show you. So this is the lateral meniscus, and behind us, suck there. Top camera. That's the popliteus tendon.
Zoom it. We'll see.
Yeah, I'll show you in a minute. Forceps to me. Clip or small clip. Because we don't expose too far. This camera. Can you see? That is the popliteus tendon. Can you see that one?
Yeah. Yeah.
That one.
Right.
And it's going behind. So it will come when we cut that one, it will come. I'll show you a bit later stage. And the medial meniscus in little osteoporotic ones. Do not go. You can leave little rim of the medial meniscus. And be careful very closely to the MCL. Clip again. As you can see, that is the MCL there. That's this camera. That's MCL. I'll show you a little later on. Can you focus there? Probably can see that one. Can you see the white structure there? That's MCL. I don't want to expose too much, but
Okay.
that one. Nibbler, small nibbler. That's a medial osteophyte which will equivalent to release. Okay.
Some people do tibia first, then later on femur. Advantage.
Yeah. I'm doing this is called measured resection. So I know what I'm doing it. If you are doing a balance in one, then you have to cut the tibia, femur, then balance it and do it. I'm doing a measured resection. This is one way of doing total knee replacement because I know what I'm cutting. So you can do femur first, then tibia. Okay. And balancing because I'm cutting two important tendons. So there's not much of balancing, only MCL and LCL, easy to balance. Always keep it simple.
Right.
And this one is important. So you take 8 millimeters, top one, can you see? 8 millimeters from the normal side, as you can see. 8 millimeters, normal, that one, probably this one, the front camera.
One question, sir. How to identify the center of the ankle joint?
Yeah,
Because that is a very crucial point.
sure. And this is just marking the interligamentous line, that's the midline. There, as you can see. And I'll come back to that in a minute. So that is the tibia, about 8 millimeters, and this is the other side. And this my angel wing, top one. Angel wing will show me two things. It will take how much, it will tell me how much I'm taking, and also the slope, because slope of the tibia is variable in different people, this camera. So you match the natural slope and adjust your slope bit more, So this should be parallel to the tibia. Can you see that my angel wing there, bit more, zoom out little. So that one is parallel to the tibial upper surface.
So that should be about 6 to 7 degrees. Is it?
It's about 10 degrees.
Yeah.
As you can see, this is parallel. So that way you match it and adjust your slope. And one more thing, I put my 2 fingers there. So most of the time it's about 3 fingers you can insert between the rod and the tibia.
Okay.
Okay, and the top one I'm adjusting, so it should be inter ligamentous line. What is the line?
Akagi line.
Huh?
Akagi.
Akagi line. Karthik says is Akagi line. Put and put the pin on the lateral side. So it's my line there should be, just a minute. Okay. I'll take this one out and I'll show you a bit more. So straight clip is there. Straight on. Just a minute. Don't put it. Don't put it. So that is the Akagi line. And can you see there? Top one. Top camera. Top camera. I want to see that. The line and the cutting jig. Tibial jig. Can you see? That line is
Okay.
parallel to the Akagi line, interligamentous line. And it should be medial third of tibial tuberosity. This camera now,
Idea.
you have 3 ligamentous, 3 points to balance. Okay, no. So it should be medial third of the tibial tuberosity, parallel to the tibia, and middle of the ankle. As you can see, that's very good question. And base of the second metatarsal. Can you show me in the bottom?
Yeah.
Zoom out, zoom out. Base of the down, my finger. Put.
Right.
Hello, look. Other side. Anjaneyali, did I answer your question?
Yes, sir.
So, line, intermeniscus line, interligamentous line, tibial tuberosity, tibia, ankle, and second. So you had 5 landmarks. And make sure you hold it, same position, just hold that one. Okay, take it out. And as you can see, I'm not cut on the taken on the medial side because that's already worn out.
Here the medial condyle is more depressed here.
What did he say? 2 osteotome. This is called
Medial.
2 osteotome technique when you're taking this one out. So you elevate on the second osteotome. I'll show you the shape of the.
Dr. K.
Okay, cut that. So can you see that the medial side I'm not taking much?
That's what I'm saying. Which is
That is worn out. Okay, go on.
which is more depressed also. No, this is medial side.
Yeah.
Compartment is more depressed than the lateral one.
So as you can see here only. Lateral side about maybe 8 millimeter. You got a depth gauge, this one, measuring one. And medial side not taken anything. Completely off.
That's
Calipers is there. You can measure it and show them. Okay. Good. Yes. So this is also important for the beginners so that you check, make sure how much you taken. As you can see, I've taken about 10 millimeters. Can you see that one? From the normal side, I was aiming for 9, but it was 10. So probably there is no 9 insert, there will be 10 insert. So probably we'll use a 10 insert.
Can you show the medial slice also?
Medial slice, okay. Show me that tibia. Tibial cut. There is not much a medial side. Can you see there?
Yeah. Almost
This is the line and only left little bit.
very thin.
Very thin. And very thin. Almost maybe less than a millimeter. So now at this stage, probably you can check the balance, how far you are. So generally, I do because we routinely two fingers. So going in easily, top. And if we lift up gently, 2 fingers going easily. That means You are okay with both sides equal. Okay.
In both flexion and extension should be there.
Yes.
Yeah.
I'll show you balancing in a minute. That one. Okay. Good. So you always measure the tibial size lateral plateau because they are the equal one. So this is, just let me see, and make sure you take this elevation because you don't cut too close the tendon there, make it equal. So this is how much? 2. Nibbler. Little elevation is there. That both little osteophyte I'm taking because it's sitting on osteophyte. Take that one out then. So measure the lateral side. It's coming to 2. Anyway, with 2, we don't have much size because it can go up and down only one size. That's a 2. Run. Good. And make sure it's in the middle. Gone. Hard bone on the middle side. Oh, enough. Sometimes what happens, other side gets elevated if you do as it happening here. Okay, good. So now rim the drill. Take drill. Ring the tibia. Make it for the okay out and slot. Good. Most of the time, 50% of surgery is done by my colleagues, so that you don't get tired. You can do more cases. Okay, pins out. Careful. We need that again. Okay. Now at this stage, you take the osteophytes, posterior osteophytes, which will improve your range of movements. Already taken a little bit, I think. That's the posterior osteophyte. You can see you have to be very careful when you're using osteotome in this area. Full control. You should not slip posteriorly. As you can see, that's posterior osteophyte, which will improve range of movement. That's called your high flex knee. And make sure maybe medial side is a little tight. Just balance and see how far it is. Okay. Slot. Notch.
So can you show the grand piano sign there?
What is?
Grand piano sign, which is
Yes, on the top. Can you see?
Yeah.
Already cut the grand piano sign.
yeah.
Can you see that one?
You can you can mark it. You can see here.
Yeah. So this is should be in the middle. Okay. So when you are not sure whether it's the middle, this notch is most of the people find it difficult. What you can do is little mark both sides and see, not marked. Yeah. And can you see those? It's in the middle. Okay, got it. My side first. One more. What happens now? I'm going to take the notch out along with PCL. So the flexion gap will increase by millimeter to 2. That's why I've taken distal femoral cut 1-2 millimeters extra. Okay, pins out. And you can see only drilling pins and in and out. Important, they do not move when you are cutting the bone. Okay. Cut. Take little bit of this one as well. Give me that me. Good. I'll just lift up any osteophytes in the back. Not there. I feel medial side is a little tight, but I'll put the spacer then decide. I don't want to, I have not released any at all. That's what we learned from robotic surgery. So you don't need to release if there is no contracture. Okay, there should be equal, both sides. Okay. That's the femoral trial. Fitting nicely. Okay, take it out. And it's important, as you can see from that camera, can you see it should fit into exactly into the cutting. Okay, give me 8. We'll try 8 first. Take that one out. Lift up. So I find it little, can you see I am not able to introduce on the left side. I did not release any. So I'll release little and come back again. Okay. Little there. Don't release distally, only proximally, whatever you do. And don't damage the MCL. This one, periastium, or Bristow. Okay, good. Back again. Little tight, but it will go in, I think. Little more, reach, little more release.
It is tight.
Yeah, little tight, because I've not taken much on the medial side, as you can see, because we want a straight knee.
Was there any flexion contracture before opening up?
No, there was no.
In case there is a flexion contracture, how to address it?
Yeah, I'll tell you in a minute. So that's gone in easily. Not easily, with a little difficulty. That's a full extension from the side. Can you see the side? No, you have to go back and show me. So before that, I'll show you the rod. Hold this one. With this camera, give me the rod. Anjane question in the beginning. So I'm introducing the rod, as you can see. So it should be middle of the ankle from looking to the top. Can you see that one?
Yes, yes.
Middle of the ankle, and most important is base of the second metatarsal. So that's, I'm happy. And if we extend the top, it should be somewhere, you can mark there, center of the hip joint.
Yeah.
Zoom out. Okay. I want a straight knee. Can you see? Can you make out? Camera is too close, that's why. Completely straight.
Yeah.
Yes, yes.
Completely straight. And I'm testing the stability in full extension. So hold take this one out. Take it out. Take this one out. So full extension and move. It's not moving. Can you see? I'm doing valgus, this varus and valgus.
Right.
Very stable. And in 30 degrees. Entire knee is not moving. 90 degrees. Can you see?
Yes, sir.
39.
Completely stable.
Yeah.
And
Extension.
patella tracking, very, very important. Can you see? I'm not putting anything on the patella. No thumb. Patella
Look
tracking
nice.
nicely. Can you see that one?
Okay. Right.
And you should not release the patella. If you're releasing patella means
It again.
there is rotational deformity. And one more trick. This one. Huh? Ikuriki. Enduku? Ekara? Banu ekara?
Minister.
Ah, sir, no problem. No. So, one more trick. So, this camera, when you do this one, you should have equal resistance. Can you see? Movement, both sides. Top one, yes. Can you see? Ah, that one. When you move around, it should be equal.
Okay.
And if it is a tight inflection, what happens is, you see more than 1/3 of the tibial
Right.
insert outside. So, I'm quite happy with that one. Still little tight, but that's okay. Okay, take it. So, we want show me the implants. You always make sure you check the implants yourself. Show the implant size. And here the medial side, top one. Very ebernated bones. I want to make some drill holes. So you can make some drill holes. Show that side. Size, that one. I think you're too close. Go up. Move back. Move back so that I won't zoom out and zoom in. Show that one. Sizes. So I can see 2.5 femur.
Yeah.
Can I have picture in picture? Yeah. 2 tibia and femur is
Same.
femoral posterior stabilized PS1 and insert. I don't open insert, but 8 millimeters. It's stable. Though I cut it probably 10, but because of the what is that variable thickness, so it's says 10, but the 8 is quite comfortable. And you should not put too much in the 8 to 10 is good.
Right.
Big people, thin ladies, so 8 millimeters, I'm quite happy. But you should not put more than 10. The longevity is not very nice. So if you put more than thicker inserts will not give long-term survival, good long-term survival. And we are making drill holes. So you open the implants, ready mixing. Second side, Banu vachinda. Banu Raman, second side just. So probably, I will wash out. Injection is there. Oh, good. Will wash out. Pulse lavage is good for this one. Little tight on this side. Okay, good. Wash. Banu Ponji. Raman. While you are washing, can I ask Raviteja? Ravi, how are we doing with the time?
Time is
Sir, it's around 10 o'clock. I think we can continue.
So shall we start a little bit other side, or what do you want to?
No, please start the other side, sir. We can continue with the other knee.
Okay, now we can ask while you are waiting. So we could probably Banu will come and join me. So we will start off little cut up to cuts. Then we'll see what we'll learn from the first knee. Because we do a lot of bilateral, sometimes we'll learn quite a few things. It was tight on the medial side. To start with. So mix. So this is the injection. It doesn't contain steroid, just all. Banu, come. You can get scrubbed, Banu. Other side you can. Give me gloves. So that's a cocktail. It doesn't contain steroid, but it contains. What all it contains? Contains antibiotic, local anesthetic, small dose of morphine and adrenaline. It's a good cocktail. Inject into the capsule, mainly into the posterior capsule. Gives very good pain relief for about 4 or 5 hours. So if you're doing unilateral, you can make them stand on the same day. So it goes into superiorly into the capsule.
What about patella? You're not tackling patella now?
Yeah, I'll show patella.
Yeah.
I think you are much ahead of me. Patella tracking is good, so I don't want to replace the patella. I'll do patelloplasty.
Yeah.
So this is important. Go close to the bone and withdraw and inject into the posterior capsule, posterior part fracture. Good. I cannot tighten the middle side. That's a very good question from Dr. Anjaneyulu about alignment. It's very, very important. It's not one checkpoint. It has to be multiple checkpoints so that you don't get missed. Small soap. Don't put it directly under the bone. Till time I saw, put a small soap to protect the bone. Cancel this bone. Wash again. Good. Dry soap. Can you see me? So make sure if so Ravi was telling other day, if you hit like this, I've been doing this practice, but I didn't know what was for. It will create a vacuum and bring all water. Can you see? Completely dry.
You want to make it bone dry. What else can you use here?
I think we have to keep soap mopping.
No.
Dry. Suction.
Any solutions are there to make it dry?
Again, the solution will make it wet. I know what you're trying to say. You want to use hydrogen peroxide. Is that right?
Right.
Because problem with hydrogen peroxide, it gives bubbles.
Okay.
We don't want any bubbles, voids in the cement. So that's the tibial component going in. Clip to me. So generally, don't replace the patella unless there's a problem with the tracking. And most of the time, Indian patella very small in size. More problems with replacing the patella. So I used to replace patella to start with, but here coming back to India, stopped unless there is a tracking problem. I don't replace it. So take the bone out. Now make sure you hold the femoral tibial component when you're pulling the femur up. Okay, good. Cement again, dry. And you should make sure you should not have any water, especially fat. Fat is enemy. That's what Ravi says. Okay, go on. Hold. Okay. So I don't put real insert at this stage. I'll put a trial one. Make sure we are happy with the trial one then. Because cement gives me enough time to play around with the trial and open the original one. Okay. So 8. And lift up.
All is 8.
This is 8.
8 size.
Little tight. Okay. Okay. Take it out. Take it out. And that looks good. Stable. So open it. Good. So make sure you see yourself. 8 millimeters. Okay, open. Tight on the middle side. Okay, cement spacer remove.
Do you need to keep the knee extended
No.
till the cement gets
Yes,
set?
absolutely. We still cement is soft, so we still. That's what I was saying. We still have little time, so that
Can put something.
when it's setting, it gives it is a smart cement, so it have more of careful, more playing time, working time, not playing time. See, cement is still very. You can see. Where is it?
Are
Very
you putting-
soft.
Are you putting a bone plug in the femoral canal?
Yeah, already done it.
Already done.
done it. Probably you missed, we missed that point to explain, but I think did it. Okay, wash again. Make sure you don't leave any cement pieces. Backside there is little. Take that one out. This one. Yeah, good. Spend some time taking the loose pieces cement because they give pain and third body wear. To leave them inside. Okay. Spacer. Not spacer. Insert. Okay.
Insert is 8, no?
That's 8 millimeters.
8 millimeters, right.
8 millimeters PS. Constrained one. Not constrained, but post stabilized. Take it out. Take it out. Take it out. Okay. Going easily. And now pressure. So show me the foot. So pressure is two ways. One hand, proximal one of the tibia. Downward, not too much. One on the heel, proximal pressure. Now I'll show you the patella. Give me. Go to caucus. And this is a nice instrument. Meniscal holder. You can see cutting the meniscus, tibial insert. You can have few of them.
Right.
That's called meniscal holder. You can see patella is made of mainly osteophytes. If I take the osteophyte, it will be very small patella. And as I showed you, patella tracking is very good, so I don't have to bother. But we all know that 20% of the people with the knee replacements are not happy to smaller or great extent for various reasons. One of the common reason being patellar pain, anterior pain still persists. So we have to be very careful. Make sure the tracking is good, balancing is good to have a successful knee.
If the patella is hibernated and completely bare bone is seen,
Yeah.
anything, then do you need
We expose the subchondral bone and sometimes make holes, multiple holes so that, so. Can you show the patella top here? As you can see, the medial side is more lateral side is not. So I take that part out. And
So if the patella size is decreased, no? What about the strength of the quadriceps? It may increase or decrease now. The length of the patella and the ligament. If they are,
so I missed that point.
Yeah.
So now I can see. Tony, Ashok at the side. Ashok at the side. So as you can see, that's a nice patella now. Can you see that one? And it's a small patella. It's only about maybe 30 millimeters.
okay, but what about the strength of the quadriceps? If you reduce the patella size, will it be same or different?
No, we are not reducing it.
Yeah.
Thickness doesn't matter because say we say here we put it femur.
Right.
So we are restoring normal anatomy. So
Nothing.
we can take few millimeters. So but with the tibial femur,
Right.
again it's away. I can understand mechanical axis.
Yeah.
Central joint line, the patella will be almost equal distance.
Right.
It's only few millimeters. We are not reducing significant thickness, but making it. So that's one knee done. So probably we'll do part of the second knee. And you can. Now Dr. Banu Prakash Reddy, my student and colleague, has joined. Can you show him? Yes. Say hello to audience. To enter India, this is YouTube. So this camera. Can you, okay. Not yes. So I'll do part of it and he'll come finish off next knee. Okay, good. That's all. One knee is done. I'll come other side. So you can ask any audience any questions on the
Okay, job well done.
Ravi can ask
Anyone is interested in asking any questions?
So this
Audience.
camera should go other side or stay on the top.
Anyone has some doubts, you can still ask.
Or any doubts on the web?
Yes. What's the
Nice.
doubt?
నేను చేస్తాను మనం కొంచెం చేసుకుంటాను లేదు ఇంత నేను సేపు ఎక్స్ప్లెయిన్ చేసిన మళ్ళీ అదే నైఫ్ సో కెమెరా కెన్ సీ ఫ్రమ్ దిస్ వన్ నైఫ్
What are the complications during surgery?
ఆల్రైట్ ఓకే గుడ్ మార్నింగ్
Madam, right.
Good morning, sir.
because she is anatomy professor so complication anything can go wrong. You can damage the ligaments. Common complication is damaging the ligaments, collateral ligaments, medial or lateral, and severe complication you can damage the vessels because we are very close to the popliteal vessels, not the artery, but vein can get damaged.
Okay, sir. Thank you, sir.
And you can damage the patellar ligament, which is very bad. It's like equivalent to amputation if you damage the patella. The results are patellar ligament. The results are very bad. Can you see that one? Can you move that screen this side? I can see. Or is it difficult? Little bit, not much. Inside knife, inside the stomach. Come this side. Otherwise, I'll stay there only. No problem.
Sir, Raviteja here. So there
Yeah,
is a
Ravi.
lot of attention towards robotic joint replacements nowadays.
Yeah.
What is your take on the present scenario?
Ravi, as you know, robotics, present robotics, still very crude. They do not do entire surgery, they assess. But that's the future. That's the future because we have to integrate the technology. Robotics does help. They help. And as you know, we are learning a lot from robotic surgery as the release, medial release, we stopped significantly. And previously we used to do stepwise release, but now with the robotics, we do not do any soft tissue release unless there is contraction. If deformity is correctable, preoperatively, passively after anesthesia, we don't have to release the ligaments and minimal release.
Sir, while doing sizing for tibia,
Yeah.
if you are not getting exactly 2 or 3, whether to go
Yeah.
for a undersize or go for above size.
Tibia doesn't matter. You should not undersize. You should not oversize. Normal knee joint means without osteoporosis, like unless rheumatoids, you can undersize little bit. Between two sizes, you can take a small size. If you oversize, what happens? There will be problem on the medial side, medial collateral ligament.
Okay.
And in case of rheumatoid arthritis, osteoporotic knees, if you undersize, it will sink. So ideally, you should take exact size, but undersizing in osteoarthritis is okay. And preferably same size, maybe little lower size if you don't have any choice. In case of rheumatoids, never undersize.
Sir, what are the extra
Did you get it?
Yes, sir. Yes, sir. Yes, sir.
Is
Sir,
that
what-
size?
Sir, Dr. Pranit here.
So we're doing same thing again. We'll just see
Hello, sir.
other side. Okay, but pass it on.
Sir. Hello.
Just wait.
Moments to me. This goes. Go. కొంచెం middle side కొంచెం రిలీజ్ చేయమని little release on the middle side.
Sir, am I audible, sir?
So don't use Langenbach's.
He's involved in surgery now.
Yes, localized pressure. So always use the
Dr. KJ, some question is
Yeah.
there from audience. Please.
Yeah.
Audience, right.
Sir,
Go
what
on.
are the extra precautions you take here while releasing in a valgus knee?
Yes, that's a good question. Always difficult to do valgus knee because correction is difficult. So you have to start from capsule. Can I have the periosteum again? Little more release. But this one. You take extra precaution. So release the capsule. Okay, but release the capsule, release the, take all the osteophytes out, maybe lateral collateral ligament. Most of the time, if it is correctable deformity, you can correct at the bone. But severe valgus, you have to do stage-wise release of the structures, including the fascia. That is that ITB.
IT
You
time.
can go to ITB and you can release the popliteus tendon as well.
No, Gerdy's tuber can also be cut along with that, I think.
Yeah, good. Omen. So you're taking about 9-10 millimeters, and in the notch, this is a good point. If you are not able to go into the notch, that means you're taking too much of a cut. If far away, that means you're taking less. As I said, you run the saw second time. See? On the medial side, because of sclerotic bone, you saw tend to come off. Okay. Knife to me. Take the block out. Can you see? Yes, you can see. Your camera become functionless, is it? You are able to see. Okay, top. Okay, sizer again. Little tight, so we'll just take the osteophyte. Nibbler.
Any tips in the closure of the wound, sir?
Closure, yes. It should be watertight because not many layers. It's only the retinaculum along with the quadriceps. So you have to be watertight. And of course, subcutaneous layer. And you should, I think I think that's a good point you've taken. See, there is a angle there. Can you see this one? Can you show this one from the top? So I made a little angle there. So you should correspond to the same angle again. It's important you match the quadriceps tendon and the patellar ligament where you're cutting from and the retinaculum. So that's a little angle. It will sit there. That's a stitch corticus put already. So you should correspond. You should not make one side loose and one side tight.
Is there a need for suction drain?
I think drains, what happens is, there is no difference whether you use a drain or not. But as such, there's routinely, it's your choice. Flat, good. Your choice. But no difference at all. You don't have to, if you're taking tourniquet, but when you use the drain, interesting.
Do you release the tourniquet before closure?
Yes, when you use, if you use do not use a drain, you must use it. I think you are going to use a drain here. Yeah, okay. Good. If you're going to use a drain, you don't have to, of course, open little later. But if you are not using, you must open the tourniquet, leave the tourniquet, then hemostasis, then close it. So this side also 2.5. We learned from other side. Okay, gone. 2.5. Take this one off. Pins.
Of late, you're doing simultaneously. No, earlier you used to do it. Now, any complications are there if you do simultaneously?
Simultaneously, see, people talk about two major surgeries, but what happens is cardiac surgery is done for such a long time. It's the fitness of the patient. I don't think just because we're doing two sides, complications are more. The complications, I feel, with obese patients, you should not do it. Over 65, probably you should be careful.
That's the problem, right?
And of course, other conditions like fitness for surgery.
Depends on age as well as the.
Yeah.
BMI,
Fitness.
BMI, and then the comorbid conditions, I think.
Yes, absolutely. But never do after 3-4 days. Never do within 2 weeks.
You'll make him walk immediately?
Yeah, same time or 1 day gap. And you are very keen on grand piano sign. I think it's
Yeah, that's.
bone is not broken here, so you can see here. Can you see that one?
Yeah. No, keep it here. Oh, now, yes. Yes, okay.
Okay. Just finishing that sign. Okay. Take it out. Gone. And of course, positioning and these things are very important because you have to. Anjaneyulu, that is used for bone block. We'll show you this time. That's the
Right.
anterior chamfer we use.
Sir, when you do this shampoo cuts, in case of valgus knee, particularly with hypoplasia of the lateral condyle,
Yeah.
how do we usually manage?
See, hypoplastic, I did not understand. Can you repeat the question again?
So in the valgus knee, we see sometimes hypoplastic lateral condyle.
Yes.
So does it affect the rotation of the implant and how do we manage it?
See, most of the time, because a small one, you don't take too much of it. But sometimes it may be underneath it. So you have to play with the size a little bit. Okay.
What you mean is.
Okay.
That the hyperplasia of lateral condyle, the doubt is that, no? How to tackle
Yeah.
this area? Right.
See, what happens is you take more of medial condyle. You do not take, like on the other side, we did not take anything on the medial side. So similarly, lateral side, you hardly take anything. You only match surface and you take more of, not too much, but more of medial side. Anything else you wanted to add, Ravi?
I think that's it, sir. I think that's how we manage it. But generally, in the literature, it has been shown that epicondylar axis varies from 3 degrees to 8 degrees
Right.
in different populations. But on average, we put it at around 3-degree external rotation when we do the mechanical alignment.
Yeah.
But just to be cautious while doing a valgus knee, whether someone has got a valgus hypoplastic condyle, as you just mentioned, we have to be cautious in cutting more of medial condyle.
Yeah. Absolutely.
What about the balancing? How to do it? Valgus is there. We'll tackle.
Balancing will be more difficult. So you have
That's
to
what-
do, because most of the time, if it is a valgus knee because of the bony wear, you can correct at the bony level. Valgus knee because of the deformity by adulthood or childhood, then you have to release the soft tissue.
Yes.
But
Like
most
more
of the
medial
time,
side.
what happens is you feel you need lot of soft tissue,
Yeah.
but do not release soft tissue in the beginning. Once you cut the bony cuts, then most of the time you
When-
will be surprised. Sometimes you don't have to release too much.
Okay.
So also most of the times with valgus knees we see in rheumatoid arthritis patients, so they have poor bone quality. So as sir mentioned, we have to be very much cautious, as well as if required, we have to release IT band when
Yeah.
it's tight
Yeah.
on the.
That has to be done.
Yes. And you have to be, see the rheumatoid, you have to be very careful. MCL, avulsion is very common. And of course, patellar ligament avulsion is common in rheumatoid. So you have to be very careful when you are, especially if it is too tight, you try to move around, especially flexion extension, you can avulse. It happened in the past and it happens many times. Okay, na? Angel wing again. So that is a slope as well as cut we are showing. Can you show me that one? And again, this camera. This camera. Zoom out. So positioning from here, I think. Can you see? Zoom out. Foot as well. Center of the ankle, second metatarsal.
Alright.
Okay. Because camera is a little away, it should come this way. Okay, gone. So to me, hold this one, hold this one.
Sir, sorry to interrupt you once again. Can you show now where exactly we put our extramedullary jig? You are talking about the interligamentous line.
Yeah, I'll show. In a minute. So the jig will be about 5 bony landmarks. That's interligamentous line. Can you see top one? Can you show this top camera? So the line, midline comes there in parallel to that one. The line on the jig, medial 1/3 of the tibial tuberosity, parallel to the crest, center of the ankle. Can you see center of the ankle there? And the second metatarsal. Not the toe, but second metatarsal. Take the pins out.
Yes, sir.
Yeah. You happy, Sai?
Yes, sir. Yes, sir. Understood, sir.
No? That's a double osteo technique so that you don't damage the soft part of the. Always second knee will be much quicker because you learnt from the first knee some of the sizes and other things, so gets quicker. Nibbler, saw back, I think little is not cut there. Okay, this side also. Okay, little.
So sometimes when we do the proximal tibial cut, we often see cysts. Some are contained, some are uncontained.
Yeah.
So
yeah, most of the time, yes, that's a good question because rheumatoid, especially, osteoarthritis, you find cysts. So you have to take the cysts out and put bone graft in. Can't leave them like that. And most of them are contained. So it's coming again too on this side, as you can see. You must match the lateral tibial plateau. Can you see? Lateral tibial plateau. So medial side is a little bigger, but doesn't matter. Okay, no. Always size for the lateral tibial plateau. Ravi, in about 10 minutes, you can plan the session so that I'll come and join you. Okay. Hammer to me.
The cyst can be filled up by
Okay, go on.
cementing. When you do cementing, no, that's filled up with this. There's no point in doing anything.
yes,
That's
yes,
what I think.
yes, yes.
Once we trial, I think probably you can.
Sure, sir. We'll take it over
And-
and carry it forward.
Generally, my first side tourniquet time is 21 to 25 minutes. Second one is 17 to 20 minutes. No.
Very
Second
good.
side always. got
Right.
off.
Time conscious.
Sir, one more thing, sir. Sir, you were telling about measured resection.
Yeah.
What is the meaning of that, sir?
Major resection means I aim to resect as per the implants.
What implants are using?
Okay.
So I don't have to. In case if using a CR knee, you have to balance because 2 ligaments are there. 3 ligaments are there.
Okay, sir.
Major resection most of the time, balancing you do at a later stage. Take it. Osteotome. Curved osteotome. Lift up. Posterior osteophytes I'm taking. Okay. Lift up. Good. See, look at that. That's a big osteophyte there.
Yes, sir.
That will improve your range of movements.
Sir, what are the precautions we take when we are doing the posterior capsular release and placing the Homans to not to injure
Absolutely,
the vessels?
absolutely, you can damage. So you should be within, once you expose the fat in the back, you're very close to the vessels. So always control, you should not go too far and do not cut the posterior condyles completely. You leave little bit, take rest with osteotome and it comes off, and even osteotome should not go too far. Okay, but
And the popliteal
Pins.
vein is dangerous than popliteal artery.
absolutely, because it's a delicate one. But as long as you're in flexion, whatever you do in flexion, you're reasonably safe. Give me the nibbler. Because flexion, they fall back and they're not tense. They're not stretched. Okay, gone.
Sir, and also sometimes when we're doing the posterior condylar cut, we might unknowingly injure the popliteal tendon. Does it really make any difference in terms of balancing, or if unknowingly if we cut the popliteal tendon, should we?
Most of the time, see, in the past we used to cut the popliteal tendon routinely, release, but it does affect because the locking will affect. So probably I would repair.
Nothing happens if it's cut. Posterior stabilizing capsule you have,
Yes.
other ligaments are there which are stabilizing it. Plus the
Generally, most of the time doesn't happen.
Okay, thank you.
Especially with the PS knee, that's advantage. Amen. Okay, take it off.
Sir, in the
Nibbler.
last 5 to 10 years, it has been shown that there's an increase in trend towards doing uni knee replacements with the advent of robotics as well. So,
Yeah.
Do we still kind of
Yes, absolutely. See, the problem in India is you do not get ideal patient. By the time they see you, most of the compartments are, to some extent, you can accept patellofemoral arthritis some degree, but I think if lateral compartment is involved or other compartment is involved, they will have symptoms. So to get an ideal patient, difficult. But yes, there's a big role for the unicondylar knee replacement, especially with the robotic, because robotic is very good in telling us unicompartment. Sorry, Bristol anyway. కొంచెం రిలీజ్ చేద్దాం పెరిగేస్తాం little tight on this side like other side, so I'll just release little bit. జరుగుతుంది కదా మనం. Okay, trial. Hammer. Good. 80 rhythm. Not sitting in. Good. So that's 8 again, little tight, but I think it's going in. So let me just. So full extension, top one. Valgus stable, varus stable. It's 90 degrees stable. And I'll just check the patella. Put the rod first before the patella.
similar doesn't.
Rod from the top. See, that's from the top. Can you? I can't see. So I can see from the top. It should be parallel to the camera. Then only you can see. This way. No, it is. Can you move the camera this side? I can. Or this camera. It's in the middle. As you can see. Yes. Second metatarsal, center of the ankle. Can you see that's the center? And because the camera should be parallel to see that one. And I'll just check the patella tracking. As you can see, can you show me the patella tracking? Can you see that patella tracking is very, very important. Without thumb, it's moving. This, huh? So I'll ask Dr. Bonnet to put the implants. Show me the implants. So I'll answer some of the questions. 2.5 to 8. Don't open 8. Camera to me. So Ravi, Jagdishwar, Anjanali, any questions? Now I will clarify.
Any doubts from the audience? Still? Anyone?
So,
Per se around the knee, sir.
Hmm.
Per se
Everybody.
around the knee, will you take any precautions, sir?
During surgery?
Can you repeat the question? I
During
missed it.
surgery. During surgery.
Yeah. What precautions?
During surgery, she will.
During surgery, per se around the knee, will you take any precautions, sir? Pre-patellar, infrapatellar, like
Sir.
that, those bursas will be there, no?
No, bursas are quite normal. Unless there's a problem, we only tackle if any problem is there. We do not go anywhere near normal anatomy. We do not disturb normal anatomy.
Okay.
So if we feel there is a problem, then only we do. Otherwise, we do not interfere with any normal anatomy. We don't go anywhere near.
The bursa
Because
getting inflamed. That
What
was-
happens wherever you expose, there will be scar tissue.
Yeah.
And scar tissue can be painful.
Thank you, sir.
When will you replace the patella, sir?
Yeah, that's a good question again. See, patella routinely I do not replace, but if there's a problem with the tracking, and probably in case where I'm doing a revision, where there's a patellar maltracking, I do. And in case of valgus knee, sometimes difficult to get a proper patellar tracking, then I replace the patella, but routinely I do not. And most of the time, you don't have to replace.
Oh,
And the results are the same, whether you replace it or not. Reoperation rate is 1%, whether you replace or not. But people, I think more and more people are
if it is
replacing patella because the patellofemoral symptoms are more. Especially other day we were discussing with Ravi, severe patellofemoral arthritis probably end up with some degree of pain even if you do total replacement because of their main problem is patellofemoral arthritis. So we have to think about replacing the patella in those group of people.
Sir, two questions, sir.
Yeah.
Whenever we counsel the patient for TKR, immediately they'll ask what is the success rate, and number two, immediately they'll ask can I do the regular activities normally? So they
Yeah.
expect the climb, stairing, and all. So please
Sure.
opine.
So never say 100% successful. No operation is 100% successful. And never guarantee any patient. Never guarantee. Tell them what is the aim of doing an operation. We are trying to relieve the pain. We are trying to get the activities of their age. See, you can't make them run like 30-year-old, though you replace the knee joints at the 65. So they have limitations because of their associated condition, their age. So they have to respect their age. So the main aim of previously we used to say the first indication of knee replacement is pain.
pain relief.
Second indication is pain. Third indication is pain.
Pain
Of course, now change a little bit, but I think you have to make them understand. Counseling of the patient is very, very important. Most of the time, what happens is you do not counsel them properly. Patient expectations are very high, and they get disappointed because you promise too many things.
Yeah.
Yes.
That is the biggest problem. So you should tell them it's not an immediate success. You don't say today operation, next week you will be successful. Tell them it will take I
Yeah.
tell them the recovery will continue up to 2 years.
Depends on physio also, right?
Yeah. And reasonable recovery up to 3 months.
Okay, sir.
Before 3 months, you can't expect. They will complain of pain up to 3 months, sometimes 6 months. Because this joint is going to stay rest of their life. So you have to tell them recovery. Some people get recovered very fast, 6 weeks.
Yeah.
Some people will take 6 months. And some continue to recover up to 18 months.
Yes.
And always there is some degree of pain in 20% of the population.
Still they have.
So as long as you explain to the patients, then I think we should be okay. Because what happens, you're always worried. If you tell too many complications, probably patients will run away, but they don't. If you tell the truth, they will come back to you.
Yes.
sir, and more in the recent literature, it has been shown that prehab has been shown a great benefit in terms of recovery.
Absolutely.
What's the length that they have to
I
undergo
keep saying to
prehab?
the patient, that's a good question. I think the patients will ask what depends on the success rate. I tell them
Physio.
60% is surgical technique. Even if you put the best implant in a bad position, doesn't work. If you put a standard implant in a good position, it will survive forever. So 60% is surgical technique. 20% is implant, because most of the implants what we do nowadays are equally good. And I don't see any difference, major difference between all these big implants. And of course, 20% is patient. They have to rehabilitation. Rehabilitation is the key part.
Important, right.
Yeah, because if you don't rehabilitate, if they don't do physiotherapy, they don't do exercises properly, if we don't mobilize them properly, they end up in flexion deformities, muscle weakness, contractures. So, patient should not be under impression that just do the operation and you will be successful. Patient doesn't have to do anything. You must explain them that there is a big role of them. Unless they are willing to take part in their recovery, do not offer them operation.
Oh, one last question, sir.
Yeah.
Post-petallectomy, what to do now? Post-petallectomy for TKR, suppose you want to replace the patella or not?
See what happens post-patelectomy, there is nothing to replace. So you can't do any replacement. Post-patelectomy, what happens is already there is weakness of the quadriceps mechanism. That's why we do not do patelectomy nowadays. We preserve as many pieces as possible, because later on it will be helpful if you do knee replacement. But I have done post-patelectomy. They do reasonably well. Probably they won't be able to climb properly. They won't be able to run or jog. But I think as far as pain relief is concerned, there is no difference. You have to be very careful when you're doing those things, because you can damage patellar ligament. You can avulse the ligament if you're not being careful.
Can you see the tracing there? Tracing cannot be seen. Tracing of the patella cannot be seen there. So how to make out this is?
Most of the time there may be some, but we don't need patellar landmark to do knee replacement. Patellar ligament attachment is there, quadriceps is there. So you have to retract laterally.
Sir, one question, sir. Last question.
Last question,
Sir,
right.
many of the times, if we suggest TKR for 70 years patient or 75, they will tell already I am very old. I don't know how many years I'll survive. So how do you explain?
Yeah, that's an interesting question. Most of the people do ask. I tell them there is no age limit, provided they're willing to accept the rehabilitation and they're physically fit. So we should not discriminate based on the age. I have patients who are 90s.
Yes.
I have one of the, senior IPS officer grandfather who was 102. He was very fit from Northeast. I did a replacement in him. He's doing very well. So there is no age limit as such. Some people, 40-year-old will be very unfit for surgery. You don't offer them because they are unfit for surgery. And if 80-year-old is fit, I think we should be careful, but you have to be very cautious. You can't do bilateral in them same time. Stage-wise, you take all the precautions and make sure you have the medical team, cardiac team, their people on board, and you correct their any existing comorbidities.
Okay. Any question is there? I will put in
Thanks, sir. Thanks.
session. Right. Thank you.
Thank you very much for your active participation.
Job well done. Thank you very much. All
Thank you.
enjoyed. Right.
Okay. Then.
Once
Thank you.
again, a very good morning to all. We welcome everyone here in auditorium and doctors joining us online on OrthoTV for live surgeries and
Can you
CME
cut off
program on the occasion of World Arthritis Day. We thank Dr. KJ sir. It was a wonderful live demonstration of total knee replacement. We are sure you all had a learning experience. We thank Dr. KL Jagadishwar Rao sir and Dr. Anjaneyulu sir for moderating the session.
To spread awareness, we, the doctors and staff of SVS Medical College, conducted a walkathon 2022 on Wednesday. We were joined by patients who underwent total knee replacement previously in the previous years in our SVS Medical College by Dr. KJ Reddy sir, students of our college and the general public. This day, we would like to raise awareness on progression of the disease and how to prevent it.
So, good morning, everyone. So, the event is just to create awareness in patients who are suffering from arthritis. The agenda is to and emphasize that this disease is curable, and definitely patients who are undergoing this kind of a problem can be definitely get back to normal and they can live their life normally. So we have done a walkathon yesterday near to our campus to make sure that everyone understand what it is about arthritis, and then how we can create awareness and what are the different managements, the different modalities of management that we can do to kind of help people get out of this problem. So there was a walk as well as followed by speeches by Dr. KJ Reddy sir and other dignitaries to make sure whoever present were able to understand what's the importance of it. We have invited patients who got operated by Dr. KJ Reddy sir before, and to our surprise, they have done a walk with us, as well as they have shared their experiences and how their life was transformed after the surgery. And we have got our faculty also, PSM sir, Professor HOD, free PSM, who has undergone bilateral knee replacement, and he has shared his experiences of how he got benefited from it. So probably as young doctors, definitely you'll see more and more patients coming with this kind of problems, because in the last 10 years, there was a lot of information that was put out regarding this problem, and there was a lot of latest advanced treatments that have been coming, starting from initial knee replacements that was started back in 80s, and we have got a new generation of implants, as well as now we are into the age of AI, which is artificial intelligence and data learning, wherein we have robotics as a tool, and we're using this robotic tools to execute the surgeries. So whatever you have seen just now by Dr. KJ Reddy sir doing it, probably down the line after 5 to 10 years, you might be seeing one other assistant called the robo with some funny name just next to us doing the surgery and helping us do the surgery. And what's the benefit that we are going to get out of it is something that, of course, as we do number of surgeries, we become perfect, but young surgeons like us who just get our training and pass out, so our hands are not that accurate. So this robotic tools and the newer technologies would help us determine the kind of a knee anatomy that patient has got, and we accordingly plan the surgery so that we give the exact knee anatomy back to the patient, and so that the patient feels that it is his or her own knee. So the literature has shown in the last 10-15 years that at least 2 patients or 20% of patients undergoing knee replacements are not happy, and the reasons are not yet known. But it is strongly believed that one of the reason is that we are not exactly replicating the anatomy. So it's an exciting future that you will be seeing in the coming years. We will have very much patient-specific approach towards operating these kind of problems. So we at SPS, we are always trying to kind of do this research in terms of collecting data, and also try to present what's happening in the present scenario. So once again, thanks everyone, and we'll now
Join for coffee break.
yeah, we'll have a short coffee break, followed by inaugural session, and followed by a couple of presentations. They're all presentations related to the arthritis management of various joints. So we'll have our faculty here, and then we'll have our inaugural as well. And we'll see you back in a couple of minutes. Thanks once again, and please do join us as soon as we can. Thank you.
The students are requested to stay back. All of the students and the staff inside the auditorium, please do stay back. The coffee break is for everyone joining us online.
Hey, boys. Hello, students. Boys.
They are going. Dr. Rakesh, you keep one of the postulated.
All the students sitting at the back, please come forward.
Done, Patel. నడు you, Krishna Reddy sir, Dr. KJ Reddy sir, Ram Reddy sir for coming to the event. Special thank you to Krishna Reddy sir being the chief guest for the event. Now we will carry on with the inaugural ceremony and the lap lightning. So we would request Dr. Krishna Reddy sir to please come on to the stage and have a seat. Dr. Krishna Reddy Garu is the secretary and SVS group of institutions. Now we would like to invite our Dr. KJ Reddy sir, Professor HOD Orthopedics, Managing Director of SVS Group of Institutions, and who's the chairperson of the event for the World Arthritis Day. Please come on to the stage, sir. Now I would like to invite Sri K. Ramareddy Garu, Resident Director of SVS Group of Institutions, to come on to the stage. Now we would like to invite Srimati Dr. Sushila Garu, Principal, SVS Medical College, to please come on to the stage. Now I would like to invite Dr. KP Joshi Garu, Vice Principal, SVS Medical College, to please come on to the stage. Now we would like to invite our Dr. KL Jagdishwar Rao, sir, Professor, Head of the Department of Orthopaedics, to come on to the stage. Now I'd like to invite Dr. Anjaneyulu, sir, Professor of Orthopedics. Please come on to the stage. So now I would like to invite Dr. Ashok Reddy Garu, Head of the Department Secretary, to please come on to the stage and grace the event. Thank you once again for all the respected dignitaries to coming on to the stage. We would continue with the lamp lighting ceremony now. I would request all our guests to please come and lighten the lamp.
Then we can next ask K. Reddy sir, Krishna Reddy sir మాట్లాడతారు. కామ్రేడ్ సార్ మాట్లాడతారంట. తర్వాత ప్రిన్సిపల్ అండ్ వైస్ ప్రిన్సిపల్ ని అడుగుదాం. అండ్ కామ్రేడ్ సార్ కూడా మాట్లాడతారు. డజన్ ప్రాబ్లం. ఓకే, అశోక్ రెడ్డిది రాసుకుంది, ఆయన కూడా ఒక 2 minutes ఇంకా మిగతా వాళ్ళందరినీ ఒక 2 minutes మాట్లాడమని జోషి అందరూ టైం లేట్ అవుతుంటారా? నేను పిలవమన్నాడు అడుగుతా.
Okay.
Reddy sir.
Okay. Now I would like to invite Dr. KJ Reddy sir to speak a few words on the occasion of World Arthritis Day and its importance on how to create awareness regarding osteoarthritis.
Good morning. Respected dignitaries on the dais, delegates, my colleagues, students, and press electronic media. Thank you very much to be part of this great program to bring awareness among the society and the general population about arthritis, which is affecting significantly. As you've seen, so in the morning, a lady, 65-year-old lady, she was affected with both knee joints. We did knee replacement. And as you know, we are live, entire India and across the globe through OrthoTV. Thank you very much for OrthoTV and Regrow, which sponsored that program, especially the Mr. Satyan, MD of Regrow company. I think arthritis is getting bigger day by day. Just to say, 7 crore people are suffering presently in India with arthritis of the just knee itself. If you take hip joint, shoulder joint, is much worse. And the majority are underdiagnosed or not diagnosed, undertreated. And they don't come to the hospital or doctor to get the treatment because they have so many concerns about the condition and of course the operation and accessibility, lack of knowledge. The whole idea of World Arthritis Day or week, we have been celebrating last 1 week to bring awareness so that they come to the doctors, make a diagnosis, get the treatment. I must say, I think 90% of the people who are suffering with arthritis can be treated without operation. So do not worry about the operation. If you come to a doctor, we will do the operation. It's not true. 90% of them can be treated without operation. So please come to see your doctor, go to any hospital to see what stage you are and what is the best treatment for you. Initially, simple medication, physiotherapy, exercise will help you to relieve your pain. Those who are overweight, reduce your weight. Simple lifestyle modification, making your muscles strong, will make a big difference for your quality of life. And we have injections, PRP injections, joint fluid injections, which will help you to relieve the pain. And of course, those 10% who need operation, we can do the operation, hip replacement or knee replacement, total hip or total knee or a partial, which is very successful. And it will make a difference for your quality of life. It will change your quality of life. So do not get worried or have concern about the treatment. The important thing following COVID, post-COVID, we are getting significant number of hip arthritis because of the COVID itself and treatment of COVID. Steroids causing necrosis of the hip joint, femoral head. leading to arthritis of the hip joint. And this is affecting mainly young people between 20 to 40 who are the earning members of the family. If these people can come early to the hospital, to the doctor, we can diagnose them early and treat them with simple operation rather than replacement. If anybody who had COVID or a steroid treatment or who take alcohol or those who have pain in the groin or in the thigh joint should go see doctor. Most of the time, X-rays are normal in the initial stages. So if X-ray is normal, pain is still there, you must get an MRI scan to diagnose so that we can save the hip joint. This is called necrosis of the femoral head due to long-term effect of the COVID and its treatment. So thank you once again for everyone participating. I hope you take this message to the society, to population, general population, and I request press and electronic media to help us, help the people to bring the awareness that nobody should be suffering with arthritis and pain. We have remedies nowadays. Treatment is so advanced and most of the treatments are safe. Thank you. Thank you very much for becoming part of it.
Thank you, Dr. KJ Reddy sir, for such a great speech and carrying the important message of how important it is to understand about this arthritis and how to manage it. Now, I would like to invite Dr. Krishna Reddy Garu, Secretary, SVS Group of Institutions, to speak a few words on World Arthritis Day.
Respected dignitaries on the dais and students, faculty members, and others, good morning to everybody. So today, he was telling me as a chief guest of this occasion. So I think I deserve the chief guest of this occasion because 10 years back, my brother, Dr. KJ Reddy, performed 2 joint replacements. So without any problem, I think I am the most successful patient in orthopedic arthritis, joint replacement, knee replacement. So I can sit, I can walk. I am walking every day, 5 kilometers per day, every day. So unless there is some rain or in travel, so I will walk every day 5 kilometers. That is my target. So I think, so I wanted to tell you because people are there from all over the Telangana and other state also. So my youngest brother is 10 years or 11 years younger to me. So when we used to go to school and come back, he used to stay at home because he was 3 years, 4 years old. So he used to hold my legs always, always hugging, because he was small and he was up to this. Always he was holding my legs. I was not knowing that time why he's always of course, with love and affection, he was holding. But so finally, in 2013, I realized. So he was holding my legs because whenever you feel problem, I will repair it. So he has done. So first he did one. So after 45 minutes, he said, so the second also, shall I do? No, you have to decide. So the second also he did. Within 1.5 to 2 hours, completely completed and the process. So from there onwards, I am very, very comfortable. So very happy. So there is no pain at all. So first, before taking voluntary retirement, I was in Geological Survey of India as a geologist, I have climbed all the, I think all the hills in Eastern Ghats, Himalayas, Western Ghats, because as a geologist, I used to climb all the, for investigation of mineral deposits. So I used to go without any problem, without anything. But when I came to Hyderabad and when we have started this in 1998, so there was little problem, but I could manage, and he was in London that time. So when he came back in 2000, so I think I slowly my legs were paining, so joints were paining. I showed him. So he said, nothing to worry, you take this tablet and nothing. And you do, anyway, you are doing regular walking, nothing to worry. So after, I have managed for 10 years like that, because we were under great tension, because every time MCA inspection, a lot of stress and strain was there. So we were forgetting this. Whenever we were feeling free, sitting at home, we are about thinking about only joints, because it was giving a lot of pain. So finally he has decided so to do surgery. So then recently my mother passed away 10 months back. So we were doing some puja. So I was sitting for 4 hours continuously on the ground, on the floor. So he was astonished. He was surprised. How you will sit for 4 hours? Your knees are replaced. So of course he always says, don't sit on the floor. But that occasion was different. So that is the comfort I am getting since 10 years. So absolutely no pain. No, nothing. So I'm very happy. And what I mean to say is, so before surgery, lot of inconvenience, discomfort, and we cannot think. I was thinking about my joints. So, but after that, so comfortable, and I'm very happy. So thank you very much for giving me this opportunity, and thank you all. Thank you.
Thank you so much, sir, for sharing us your experience, and you can clearly see how it can impact families with the expertise that Dr. KJ Reddy sir has. He has clearly given another life to Dr. Krishna Reddy sir in terms of moving, walking, and other things, and it's similarly doing similar kind of society in which everyone is whoever is crippled, whoever is going through a lot of trouble, they have came back to life and they're living their life normally. So I would like to thank once again all the dignitaries who are on the stage. Now we would continue again with our CME, and I would like our dignitaries to please have a seat, and we will carry on with our talks. Thank you so much.
Okay, thank you once again. Thank you once again. I think this is, as you know, this is OrthoTV and a few YouTubes live you can watch on your phone. If you type YouTube, OrthoTV is there, and quite a few channels. Our digital orthopedic surgeon is there, Dr. Sai. I think he is transmitting live as well. Thank you once again. I think the whole idea was to bring awareness among the general population. Thank you. Well done.
It is now our honor to invite Dr. KJ Reddy, sir, our esteemed Managing Director and Head of Orthopedics Department, SVS Medical College. He's one of the most renowned joint replacement surgeons. Sir will be talking about advances in the management of AV and hip.
No? Good morning once again. I think I was talking about the avascular necrosis of the femoral head, which is affecting significant number of young people.
आप तमाम नाजरीन का T9 TV न्यूज़ में खैर मकदम है। आलमी यौम आर्थराइटिस के मौके पर SVS हॉस्पिटल व मेडिकल कॉलेज की जानिब से वॉकथॉन का एहतमाम किया गया था। इस रैली में मशहूर माहिर ऑर्थोपेडिक सर्जन डॉक्टर KJ रेड्डी, मैनेजिंग डायरेक्टर SVS मेडिकल कॉलेज एंड हॉस्पिटल, राम रेड्डी, रेसिडेंट डायरेक्टर डॉक्टर जयराम रेड्डी व दीगर तुलबा व कॉलेज स्टाफ के अलावा अवाम की कसी तादाद ने शिरकत की। इस मौके पर मुनक्किदा एक प्रोग्राम को मुखातिब करते हुए डॉक्टर
All right, okay. Something else was coming at me. Connected to news channel, I think, yeah. So I think previously, the avascular necrosis of femoral head was not very common in the sense we used to see maybe once in a week or 2 weeks, one case in 2 weeks. But now we see about 4 or 5 every day. Previously, alcohol was the commonest cause. Idiopathic was another cause. Steroids, especially, I think I'll stay back, please. Steroids was other cause because of the renal transplants, rheumatoid, other conditions where steroids were used. Following COVID, it's become very common because of the COVID itself and steroids used to treat the COVID. As you know, COVID can cause thrombosis of the micro vessels, leading to death of the femoral head, leading to arthritis if we don't treat properly. What happens is the femoral head loses blood supply over a period of time. It's not sudden loss, over a period of time, which will lead to death of the part of the femoral head. Like in MI, part of the heart becomes necrosis because of loss of blood supply, similar to that. Unfortunately, what happens is if you take X-rays initially, X-rays will be perfectly normal. So most of the cases are missed. That's what I was saying. People complaining of pain in the groin or thigh pain should get MRI scan to see the initial stages. So there's various stages in MRI scan, stage 0 to stage 4. Somebody. And what happens is it's important we diagnose early and you treat early if you being careful. And there's so many ways, so many theories have been postulated, how it happens, so many publications. Till now, there is no effective treatment for AVN apart from total hip replacement. So the goal of treatment would be to improve the blood supply, remove the dead bone, form new bone, and stop the progression of the disease and save the natural hip. That's the aim. So what we do is, it's like a stem cell therapy called OsGrow. So what we do, we take bone marrow, send it to the lab, they grow stem cells, we inject back into the hip. Previously, the treatment options was core decompression. Just decompress the hip with the drill. Invariably, they used to progress. There's enough evidence to say all the core decompression patients invariably progress and majority would need hip replacement. Second option, second generation was core decompression with the BMAC. That means bone marrow aspirate concentrate. We take the bone marrow, put in a centrifuge, isolate so-called stem cells, inject back into the femoral head. But we don't know how many cells are active and how many cells going to convert into osteoblasts. So this OSCRO is a technique where you take the bone marrow, but don't inject immediately. You send it to the lab, grow the cells. It takes about 6 weeks. When it becomes about 5 million, 4.8 million, you do the second operation, or the main operation. Take the, under X-ray control, take the dead bone out and inject the stem cells. So ideally stage 1, 2 are ideal for regrow or OSCRO. If head is collapsed, it's not suitable because it will progress. As you can see in the MRI, that's the avian part. In this stage, you can treat because the head is still circular. Whereas here, head is already collapsed. That's the pelvis. That's the pelvis, hip joint. And hip joint still, head is spherical. This is a normal head. Where it becomes collapsed, you can't treat. These hips, results won't be good. So what we do, we take the aspirate from the iliac crest, send it to the lab, they grow the osteoblasts. So the dead cells will be whatever other pluripotent cell will be dead. Only cells will have multiple potential. They grow into by what is a cell, what is that cell? Cells are ready. What we do under X-ray control, we put the guide wire where the lesion is there, mainly the center towards center, and make a drill hole. And with a spoon, we take all the dead bone out. As you know, some of the students, this is the hip joint, this is the pelvis, this is the acetabulum, this is the femoral head, ball of the hip joint, this is the thigh bone, and this is the trochanter. So we are under X-ray control. We are not opening the joint. Under X-ray control, we have made a little hole with a guide wire, as you can see here. Then put the drill and with a spoon, special spoon, take the dead bone out. Small incision like that. And these are the cells in the mix with the fibrin. Previously, biggest problem was we inject the cells. There was no matrix to make them stabilize. So we put in a fibrin, which becomes very hot. And cells contained within the fibrin, they stay there for a very long time because it's not affected by compression. Otherwise, they'll come out. It solidifies, becomes hot in about 10 minutes. And of course, we have to be non-weight bearing 6 weeks to 3 months. Done about 251 cases with the 2 years minimum follow-up. So you can see the results average about 58 proof. So we have about 80% doing well. So 80% doing well means 80% of the cases we were able to save the hip. See, the whole idea is if the head is maintained spherical without collapse, it will not progress to osteoarthritis. It may not repair the head, but it will prevent further damage, further progression. That is successful. Sometimes it can repair, part of the new bone can be formed, which is good. And it might progress in some cases, but slow progress. So still takes arthritis to set in long time. Maybe if it postpones for 10 years, that's good enough. And some of the, you can see, some cases which are subchondral, we have to be very careful because they'll collapse. And as you can see, this MRI scan, this X-ray, we have done core decompression with stem cell impaction. And already this is how many weeks? Few weeks following. You can see that's a track, and there is some new bone formation around there, both sides. This is a bilateral one, as you can see. And this is about 6 months post-op. You can see bone is well formed all around and is able to squat. He came with a painful limping, not able to walk properly. So that's what we achieved, which we can't do following hip replacement. And young people, most of them are young people. In young people, if we do replacement, they need multiple operations. If we do hip replacement at the age of 60, probably it would last life. But if we do it 20, 25, it won't last that long. It might last 10, 15 years. So we want to save the natural hip. This is a patient you can see getting up. That's a video. Probably it will play. It won't play, I think this. So they can walk. And another patient, as you can see, this is a pre-op, few weeks and a long term. As you can see, the new bone is formed here. And the most important thing is the shape of the head maintained after 6 months. That's more important. As long as the head is spherical, the osteoarthritis will not set in. And he can squat, he can sit cross-legged, and few more cases. So the take-home message is, it is, of course, still in the beginning stage, and selected cases will have good results, provided you diagnose early. If head is involved more than 50%, not suitable. Stage 3, 4, not suitable. If it is close subchondral, if we do the procedure, it will collapse. So it's not suitable. So selected candidates in stage 1, 2, probably 2A, they have excellent results. And it will eliminate or postpone or retain original hip. Thank you very much for patient listening.
Thank you very much, Dr. KJ Reddy sir, for sharing us your thoughts on hip preservation, particularly post-COVID, as we see many patients in our clinics having avascular necrosis because of COVID, as well as the use of steroids. So now I would like to invite my friend, Dr. Prashant from Dubai. He's working as a shoulder and knee expert at Max Cure Hospital in Dubai. He has done his fellowships from Johns Hopkins, and he's now practicing in Dubai. So I would like to ask him to present. So he's presenting online today. We will ask him to join now.
Hello, Ravi, can you hear me?
Hi, Prashant, can you hear us?
Yes, I can hear you. Can you see me as well?
Wonderful. I would like to invite Dr. Praneeth sir to join the stage as a moderator, please. And Gopinath sir also, please. Over to you, Prashant. Thanks for joining. Of course, I've asked you to join the last minute, but thanks for making your time. And I'm sure you have got surgeries in the afternoon and you travel, but won't hold you much time.
No, Ravi, thank you so much for having me. I'm so thankful to the SUS Medical College for having me and celebrating World Arthritis Day. Thank you, Dr. Reddy. I've heard a great deal about you and really appreciate this invite and to present our work on shoulder arthritis. I think shoulder arthritis is one of the key problems which we have in our society. And as the aging population is growing around, especially in Asia, and we have it really disables them. I see a lot of patients when I was in India practicing. I see a lot of patients after 60 years old. They think that, okay, fine.
Prashant, can you hear us?
Dr. Prashant, I work at...
Yeah, please go ahead. I think we have got some network issues there.
Understand shoulder joint arthritis better, sharing my experience with you today. So I don't have any financial disclosures for this talk. I'm a member of American Shoulder and Elbow Surgeons. My experience from the Hopkins and Seoul National University, Korea, has really taught me about the advances of how we can treat the shoulder arthritis. My work also with the journals, being the top reviewer for Clinical Orthopaedics and American Journal of Sports Medicine, especially in the shoulder part, has helped me understand a great deal in the years of my fellowships and practice. So the topics I'll be discussing, the advances in shoulder arthritis treatment would be first is what are the advances in diagnosis and the treatment part. In the diagnosis, I believe that there are many young surgeons out there, and what I would really recommend is if you're treating anyone with shoulder arthritis, you should really hit some of the key points and do not miss on them. If you see this kind of X-ray of the shoulder in which there is absolutely no joint line present, which means this is advanced arthritis, we really need to know, because the age of the patient is a major factor. If the treatment of someone who is over 60 is different than someone who is 40 when they present with this kind of X-rays. The history of trauma is really important. If the patient never had any history of pain before, we may not have to do anything for this patient unless all the symptoms have started up the trauma. The chronicity of the symptom tells us when the patient complains of night pain, that is when you know that you got to do something more than just medicines. This patient may be a candidate for surgery and will benefit, because the quality of life is directly proportional to how the quality of sleep. We also need to know the level of activity the patients are doing, because if someone is doing very high level activity, they want to go back to cycling, to being very active. For them, options like reverse shoulder arthroplasty or a very constrained arthroplasty is not very good. Another key thing, now this is not just shoulder, but this is if you're treating any patient for anything. I believe that setting expectations for the treatment is one virtue or one wisdom of clinical practice, which I've understood. If you tell the patient that, oh yeah, this is a fantastic surgery, you'll be able to go back and do 100%, whatever you want, that does not work. We got to be honest with our patients. We got to tell them that, hey, listen, we're going to try and make you better. And the chances, and we always quote the literature, that the chances that after this particular surgery, your improvement is 90%, and these are the potential complications, and you let them sleep on it and take an informed decision. And that really helps because if someone has very high expectations of the surgery, even if you do a really fantastic joint replacement for them, they come back with little pain here, little pain there. And then, that's because, oh, doctor, you did not tell me before that I may have some pain in the post-operative period. So, what I've learned over the years is like, instead of trying to that, okay, it will improve you, and this is the realistic expectation. Another thing I would recommend is when you're dealing with patients with shoulder arthritis, is a lot of times I see X-rays like this done, and they don't really give you much information of the joint itself. If you see here, now what we prefer at our institute is doing the true AP X-rays which really shows us the joint line and how much arthritis has progressed. And we need to educate our radiology technicians. We need to educate our nurses in order to get these kind of X-rays which you see on the right side. We also routinely get axial X-rays. So these are the two X-rays which we get for arthritis patients. Is the true AP X-ray, and the second one is an axial. Even this is not a particularly good X-ray because you don't see a lot of scapula here. It's so important to get the X-rays with scapula and not with just the humeral head, because the relation of the glenoid with the scapula is everything we need to know from the X-rays. At the end of your clinical history taking clinical exam and your X-rays, I think you have good enough confidence. You should be good enough to kind of make the diagnosis of the patient and decide the treatment. Because I've seen a lot of people jump on MRIs when they hear people's arthritis, I think, or shoulder pain. I think that's not the correct step. I believe that X-rays and your good clinical exam still hold a lot of, I think, importance before you diagnose the patient. So if you see on the left side, you should be able to know if the patient has a primary arthritis in which the subacromial space here is relatively preserved, as against to this X-ray in which the femoral head has gone all over the top on the acromion, and this is called as astabilization of the shoulder. So these two are the most common clinical scenarios you would see when the patient is coming with shoulder arthritis. One is the primary osteoarthritis, and second one is an arthritis which is due to a chronic cuff tear left alone for a long time. And this should give you a good a chance of having diagnosis. You should also be able to, based on the x-rays, rule out any other avascular necrosis or any other pathology that the patient may have, but these are rare. Now, when do we do MRIs in the patients? And I cannot emphasize on this more that the MRI is not a very sought after investigation when it comes to shoulder arthritis. We do it only in cases of advanced arthritis, only in those patients in which we think that we will do an anatomical total shoulder, and we want to confirm the status of the rotator cuff. And that is, I believe, 5 to 10% of the patients. So in advanced arthritis, MRI is not the investigation of choice. If you see the shoulders are a little different than knees, because all we see when we open up the shoulder, and this is the glenoid in the surgery, is the face of the pathology. How this glenoid is related to the back scapula is something which we want to know during the surgery. So in order to understand the anatomy better, I think if you're planning for a joint replacement involving glenoid replacement as well, what the next investigation you should really do is a CT scan. And this is strictly only for the patients in which you're planning surgical planning, either anatomical or glenoid or reverse shoulder arthroplasty, in which we also replace the glenoid component. Now, this man right here, Giles Walsh, is a great French surgeon, and he's been persistently working for the last 20 years and telling us how to treat patients with shoulder arthritis. One of the key things which you want to know in your surgical planning is the glenoid bone loss when you're looking in the axial plane. So what he proposed is this modified Walsh classification. If you see here from A1 to C, the glenoid erosion posteriorly gradually increases. This is very critical if you're a shoulder surgeon, if you're planning for any of the shoulder arthroplasties involving glenoid. You need to know this kind of classification, because the treatment options, if you're doing anatomical or reverse, completely changes. What we have also understood as the retroversion, the measurement of the retroversion in the axial plane is really key to decide the treatment. And this is the rough 15-degree cutoff which we used in Hopkins. And I'm not saying everyone uses it, but this is what works for us. If the patient has a retroversion more than 15 degrees, we go towards a reverse shoulder arthroplasty. If the retroversion is less than 15 degrees in primary osteoarthritis, we go towards anatomical shoulder arthroplasty. Another way CT scan kind of help us is that it creates this 3D images. We put it in a commercially available softwares. If you're whatever company implant you're using, you can just you can ask the company person, and most of the leading companies have this kind of 3D planning software. What we do is we put patient CT scan in there, and then it lets us play around putting your implant here and see, based on your bone loss, which kind of implant you can use, which kind of augments you can use. And in shoulder arthroplasty, this is absolutely invaluable. I would say that, you know, all the leading surgeons, whenever I attend European meetings, American meetings, all of them, they talk about having a CT scan and having a good plan, especially in cases with severe glenoid bone loss. So this is one of the advances in shoulder arthritis management, which has completely changed the game. They also allow you to change the implant from reverse to anatomic. If you see here, this patient has a glenoid bone loss, but we can simulate this, that, okay, if I use an augment like this, and how much augment to use, we can prepare for the surgery better. We can order these implants in the beforehand, before going into the case. And this has really helped us in our clinical practice. This also shows us after we put the base plate and we put the whole implant, and see if our implant this is very important, the seating of the implant. If the implant is completely seating on the glenoid, or there is a bone loss and it is not covered and we need to use the augments. Going to say just that CT planning has really improved our understanding of how to do these surgeries, and we frequently use it in our clinical practice. Moving on to what are the advances in the treatment of shoulder arthritis, I'll be talking about some simple things and some really advanced things. In the non-operative treatment, whenever a patient comes with shoulder arthritis to you, my recommendation, if you're seeing them for the first time consultation, my recommendation is to always give them a non-operative management, even if they have a severe arthritis. The reason being is that, it really helps them to trust you as a surgeon that, okay, we tried some medicines and physiotherapy, it is not working, and now it's the time to go on. It will help you build the trust with the with your patient. Another thing is a lot of times we may want to send the patient for physiotherapy, but if they have arthritis, but it just makes them worse, because one thing you have to do is you have to give them pain control. Unless we have pain control, patient will never be happy. Even if they're improving, they will never be happy. Doctor, I still have pain. So don't be shy in giving pain medicines and be aggressive in it. And once they control their pain, they can slowly go into physiotherapy. I personally do not prefer a lot of patients to go to physiotherapy. And what I prefer is for shoulder arthritis is to give them this kind of leaflets or this kind of reading material. You can give them. Nowadays we have a lot of videos on the YouTube. You can create your own videos and use other videos of stretching exercises. Once the pain control is there, you can ask them to do these exercises 2 to 3 times a day and monitor them, I would say, on a monthly basis. If that's not working, they can benefit with the physiotherapy. But use non-operative management, and that should be your first line of defense against shoulder arthritis. Another way which we have realized over the years that we can relieve the pain, especially in patients who have severe pain with arthritis, is by giving them intra-articular injections. One key thing to note here is a lot of people give it in the subacromial side, in the subacromial space, instead of the glenohumeral joint itself. Now, that is something which your clinical exam will tell you. If the patient has impingement, or they have terminal pain in terminal range of motion and not during the range of motion, they can have a subacromial injection. If the patient is having typical glenohumeral arthritis, I recommend to give the injection in the glenohumeral space. So you can give an injection to the patient, but if it's given in the wrong compartment or if it is given in the wrong place, it may not work. So a clinician also has to know where to give the injection in patients with arthritis. We give these injections regularly because they work really well over a period of 6 weeks to 3 months. You tell the patients clearly that they work only in 70% of the patients. In 30%, even if you give it in the right space, it does not work for some reason. Now, PRP injections is something which you hear of a lot of times, even knee arthritis or shoulder arthritis. In our opinion, and we don't use it at all in our practice. And we have realized that patients do not really benefit. They spend a lot of money, in these injections. They don't benefit, and you ultimately lose your credibility because this patient will not be happy. They will not come to you, and they will go somewhere else. This is just our practice, and probably someone else has a different approach to this. Stem cells. We have done a fair amount of research. This is a paper in Clinical Orthopedics and Related Research. About if there is any clinical evidence of giving stem cell therapy, and this was for knee arthritis, but I believe that we apply this also in our shoulder arthritis patients. Stay away from stem cells as of now. They are not advanced at the level in which they would to imagine that if we take out the stem cells, or we take out the blood and we expect that to convert into a cartilage. We are not at that level in the science. I believe that we can do that, because if you offer this patients, they will cost you hundreds of thousands of dollars, and that's just wasted money. And as of now, we are not at the stage to recommend it. Recommend to do, and this is not something we practice. What we practice in terms of injections is only steroids. And we also tell the patients that the pain is not going to go forever. It is going to go only for 3 weeks, 6 weeks to 3 months. One of the treatments which has been tried in the past for arthritis is arthroscopic debridement. I believe that it has a limited role in young patients, especially those patients who are in their 40s or 50s, and these are heavy weight lifters who have abused their shoulders, weightlifting all their life, and they come back to you with shoulder pain. All they want to do is go back to the gym. In these patients, we don't really want to offer them any kind of shoulder arthroplasty because they will not be able to go back to the gym. In this select group of patients, I believe that arthroscopic debridement may have some role. What we do in this case is arthroscopically we remove the synovium as much as possible. We do subacromial decompression. remove any kind of, if you see this big spur line here, if we remove any this kind of spur, and that is not an easy surgery to do, I would say it's a very difficult angle. So I would recommend anyone taking up this surgery to have a lot of expertise into shoulder arthroscopy. There's another, we also remove any kind of other pain source which patient may have, biceps tendonitis or AC joint pathology. Those are dealt with. So basically, we try to take out as many pain sources as possible, and we tell the patient that we are not going to improve your arthritis per se, but we are going to take out your pain. Your pain is going to go down 70%, and maybe with that you can go back to your high level of activity. Anna et al. Published that the 63% success rate at 10 years, patients were able to avoid their joint replacement, and these are really fantastic results. But we were not able to recreate this. I believe that these patients are very high level athletes, and we need to tell them that your arthritis is advanced, and this procedure may help, but don't promise them 100% results. Another way to deal with advanced arthritis once proposed was hemiarthroplasty. And in 50s and 60s, this was the main goal for a lot of end-stage shoulder diseases. But with the advent of anatomical and reverse shoulder arthroplasty, in which we also replace the glenoid side of the shoulder joint, with the advent of these, there are very limited current indications for hemiarthroplasty, in my opinion. We usually use it only for the young patients in which the rotator cuff is really well, and also the patients with very good humeral bone loss. So young patients coming with head split fractures, which cannot be fixed with open reduction internal fixation, may be candidates for hemiarthroplasty. And also young patients, sickle cell disease or any other causes, they have avascular necrosis, good bone stock in them. We want to preserve the glenoid, only in those patients, the hemiarthroplasty works. One of the issues with hemiarthroplasty, which we have realized, is if you do it in patients who do not have a cuff, then they have this kind of superior escape. The patient will keep going up. Patient, whenever they try to lift their arm up, they will not be able to do it. There's poor function. They may have some pain relief. So be very careful that when you're offering hemiarthroplasty to a patient, if their cuff is deficient or not, they should get an MRI in this patient and check about the status of the cuff. Total shoulder arthroplasty, in which if you see this glenoid base plate here, this is the glenoid. There's a polyethylene component, and which you cannot see in the X-rays right here. But these are the recent advances, which I believe that we use it for patients who have intact rotator cuff and also do not have severe bone loss, and also in patients with rheumatoid or other immunological arthritis. Bad ideas to do total shoulder arthroplasty are patients with severe glenoid bone loss, because the glenoid component cannot be fixed very well to the polyethylene component cannot be fixed very well to the glenoid. So be aware of all the classifications which I talked about. You should know, you should do a CT scan. You should classify the patients in the axial plane, how much glenoid bone loss is, because if the patient has a glenoid bone loss and you miss it and you try to do a total shoulder arthroplasty, you may end up with not able to fix them properly using a total shoulder arthroplasty. So contraindications for total shoulder, I believe, are reverse severe glenoid bone loss, rotator cuff tear, any patients with paralysis or Charcot's joint with bone loss or Parkinson's disease are not good candidates for total shoulder. They would be candidates for a reverse shoulder arthroplasty. A lot of times, patients, when you offer them any surgery, they ask you, okay, doctor, how long it is going to last? Now, I particularly, I mentioned to them the literature and what we have understood over the years. So the current literature, the latest one which we have, is that an anatomical total shoulder arthroplasty usually lasts about 85% of the cases in 20 years, which I believe is a decently good result to offer. Now, the anatomical shoulder arthroplasty has undergone several design modifications. On the humeral side, as you see here, these are the old designs with long stems. But recently we have this kind of short stems. We also have no stems. available. And I think this the main reason for this is so that we can preserve the bone stock of the humerus in case the patient needs a revision in the future. We also have platform systems in which we can just we can keep the stem intact, and on this platform we put a reverse. So to convert an anatomical into a reverse is easier revision, and these is also advances in the anatomical TSA design. On the glenoid side, if you see here, the old designs had a metal component for the glenoid, but the recent they have a very high failure rate in terms of loosening and needed revisions in high number of patients. So the recent designs are they are cemented polyethylene here, and they come in various in recent designs. They come in various shapes and forms, and they in terms of wedges, hemi wedges, step wedges. Based on the glenoid bone loss, you can fit them right in, and our CT scan planning will help us to decide which kind of wedge we want. And so we are really making good advances in terms of management of shoulder arthritis with these kind of implant designs. At Johns Hopkins, what we realize is that over the period of years, the main issue with total shoulder arthroplasty is that the cuff fails. And if that happens, even the subscapularis fails, then the patient's function will go down. And this has been our experience. This has also been reflected by the experience of multiple registries, Australian registries, the American registries, data is that over as 2005, when after reverse shoulder arthroplasty was modified and introduced as a successful operation, the number of total shoulder arthroplasties in our institute and outside as well have started to go down. About 2014, they had good results of reverse shoulder arthroplasty. So anatomical total shoulder arthroplasty was being done less. So just to reiterate on that point is that, the number of patients we do about 100 to 120 reverse shoulder arthroplasties at Johns Hopkins. In our institute at Dubai now, we do about somewhere in between 25 to 50 cases of reverse. And once in a while, we have anatomic. In the past 1 year I worked here, there's only one anatomic which we have done and no hemiarthroplasties. So going ahead, the advances is reverse shoulder arthroplasty. This particular implant right here is the latest arthroplasty option which we are offering to our patients. This is also relevant in Indian patients because we have patients with osteoporosis. So in order to kind of fix the implant on the glenoid side very well, I think reverse shoulder arthroplasty holds a great promise in our Indian patients who you typically have severe glenoid bone loss or advanced reverse rotator cuff arthropathy. So this reverse shoulder arthroplasty, this is one of the initial designs which was introduced by Gramont in 1990. It became a hit in Europe and in America. But these initial designs, they were medialized glenoid. It means that the base plate of the glenoid was as close as possible to the glenoid bone. And these, because of the medialization, they were not stable. Or I would say that in a lot of patients, they had issues with instability and base plate loosening, which is a bad problem. But in recent advances, the glenoid component has been, if you see, this was the medialized, the red dot is where the medialized component was. But in recent advances, we want to lateralize the glenoid component. If you see this green one, we want to put the base plate of the glenoid as far as possible. Now, this was introduced by Mark Frankel in America. And the way Europeans went was they wanted to lateralize at the glenoid humeral component and not the glenoid. So now, because of the success rate of reverse shoulder arthroplasty, now it is not being done just for cuff tear arthropathy. In shoulder, if you have shoulder arthritis with reverse, with severe glenoid bone loss, we do a reverse. For fractures, old elderly patients with 3-part, 4-part fractures, difficult to fix, reverse shoulder arthroplasty is a great option even as a first operation instead of fixing them. Patients with dysplasias, patients with dislocation arthroplasty, and patients with fixed dislocations. Going to say reverse shoulder arthroplasty has become kind of the preferred choice for patients with advanced arthritis in properly indicated patients. Now, I was talking about glenoid lateralization, so we can fix the glenoid base plate right there for a reverse shoulder arthroplasty, or we can use this kind of bone graft which this is something introduced in the France, and it works in their hands. It works really well, but there are concerns of bone graft incorporation, or the bone graft does not heal, then your base plate is just lying there in the air. So what they have developed is metal kind of augments, in which the lateralization happens at the glenoid surface, in which the metal is in between your glenosphere and the bone itself. And these kind of customized glenoid, I will talk about them a little later, which is for patients with very severe arthritis.
Prashant, can we just wind it up in the next few minutes? Yep.
Yeah, I'm just at the end of it, just standing it. So we have very good results about lateralized glenoid implant at our particular institute. We have published it in JBJS. Lateralized humerus in our institute has not worked, so we go with lateralized humerus. The survival of the reverse shoulder arthroplasty is about 85 to 90% at 10 years, which I believe is fantastic results. This is our current experience. I've worked with reverse shoulder arthroplasty in 4 countries, and I believe it's a great tool for pain relief. Function is limited. They cannot lift up very heavy weights, but usually if they don't have pain, they are particularly happy. This is the latest from reverse shoulder. This is probably one of our last 2 slides. Is if patient comes with this kind of severe glenoid bone loss, we send this CT scan to the company, which they make this kind of fancy implant for you, which addresses the glenoid bone loss, and they send us back to this model. If we accept this model, then the patients then they send us the final implant. But these are very, they don't have any long-term follow-up yet. We have done about 20 of these cases at Johns Hopkins, and we are still waiting for the results. The patients are doing good at 2-year follow-up, but this is the latest. It will be a while before it comes back to India. So in the summary of the talk, proper diagnosis of shoulder arthritis is must. Non-operative treatment is still the first line of defense, and pain relief is key. Get the CT scan if you're planning for a surgery, and set the realistic expectations for the patients. Finally, thanks to my friend Dr. Ravi for having me here. This is our photo in Korea, which was about 5 years back, and we didn't really know where your life is going, but so far so good. We're doing okay in life, and we've been around the world. And one thing which I've learned is that unless you spread your wings, you will have no idea how far you can fly. That's my time. Thank you so much.
Thank you very much, Prashant. It was nice meeting you. Probably next time we'll have a physical meeting in Hyderabad. It
Absolutely,
was excellent presentation with so many cases and publications. I can see you publish so much, and they need people like you to run the future. Thank you once again to be part of the program. Any questions? Then probably because
So can we have the Q&A session probably after the next talk and live surgery? Thank you once again, Prashant. It was amazing to see you presenting, and I hope to see you again. As the sir just mentioned, we would invite you to SVS one day and present in physical. Thanks once again.
Thank you so much. Thank you so much, and for having me. It's an honor and pleasure. And I'll be around for the Q&A. Thank you.
Yeah. So next, we would like to have Dr. Rajiv Reddy sir from Apollo. He's a consultant orthopedic surgeon focusing mainly on the oncology, ortho-oncology. Over to you, Rajiv sir. So please finish the talk in next 10 minutes so that we can carry on with the live surgery.
Yes, right. Can you hear me?
Yes, we can hear you, sir.
Yeah, good afternoon, everybody. I would first like to thank Dr. KJ Reddy, sir, Dr. Sai Tarun Reddy, and the organizing team, including Dr. Raviteja Rudraraju. And while I would have been pleased and I would have loved to have been there, but due to some issues, I'm going to present my advances in orthopedic oncology as an online presentation. So when we come across an X-ray like this of a 32-year-old lady with pain in the left hemipelvis and swelling, and with history of surgery in the same area for similar symptoms 2 years ago, the first thing that we do is get an X-ray done and look back at the previous histopathology reports, which told us that this patient had a kind of bone cancer called chondrosarcoma, which was a very low-grade cancer. Even though the X-ray could not give us much information, the MRI clearly told us that this is a huge lesion extending from the lateral aspect of the sacrum all the way to the ilium, and it had a good intrapelvic component as well. So in this kind of a situation where we see an X-ray and an MRI like this in a young patient, the first thing that we'll think of is to remove the tumor en masse so that the patient has no chances of recurrence later on. But this involves a great deal of planning, especially in a difficult location like this. We can see that the tumor is very close to the bladder as well as the rectum and the great vessels. And on the axial images, we can see that it is going through the sciatic notch, and probably the sciatic nerve is very close to the tumor and being pressed by the tumor as well. The CT scan and the 3D reconstruction told us that there is a tumor corresponding to the MR images, intrapelvic as well as extrapelvic component, with partial destruction of the sacrum as well. This kind of imaging is now routinely done in almost all centers, but in these kind of complex cases, we hardly get a 3D picture or we hardly get a mental 3D image of the entire tumor, which is absolutely essential for us to perform a wide excision surgery, wherein we save the normal pelvic bone, the nerves, and the vascular structures, but we remove the tumor without spilling it or contaminating it intraoperatively. That is the aim of this kind of a surgery. Since we have an in-house 3D printing lab available, we were fortunate enough to sit down with the engineering team and prepare these kind of models where the red is the actual tumor, the chondrosarcoma, and we can clearly see its location as well as its extent, and the white is a normal bone. This kind of 3D images, this kind of 3D models help us in counseling the patient and also planning the surgery in great detail, because the dimensions on this model are exactly the dimensions that we will see intraoperatively when we do the surgery. We went ahead with the surgery and we were able to save the sciatic nerve and remove the total tumor with wide excision with good clear margins. We also use 3D printing routinely to create these kind of 3D printed plates, especially when we have to deal with pelvic surgeries and complex anatomical surgeries. 3D printing is now routinely used in these kind of cases where a 20-year-old gentleman with a popliteal swelling was advised surgery 5 years ago. He refused surgery, but now he's concerned that the swelling is increasing in size. And we can notice on these X-rays that these kind of tumors, essentially this is an osteochondroma, is in a very difficult location where the popliteal artery and where the posterior and anterior tibial artery bifurcate from the popliteal artery. To get a full idea of how close the vessels are to this tumor, we got a 3D printed PDF done, and we can see that the popliteal artery is actually coursing through the tumor before it bifurcates. And the 3D images helped us in creating a 3D model, and we could plan the surgery in a very effective way. Similarly, when we encounter difficult bones like the talus, where we see recurrent tumors, recurrent giant cell tumors, and the talus is a bone which does not tolerate recurrent tumors at all. Hence, we had an option of talectomy earlier, but now because we have 3D printed metal plates and metal bones available, we can sit down with the engineering team and create these kind of 3D printed taluses, which we had done. And usually this is prepared in about a week to 10 days time, and then we reinsert it back into the patient's ankle so that they have good function and they can walk well. Also, orthopedic oncology has developed in leaps and bounds, as indicated by this case of a 16-year-old boy who presented with pain in the left hip. He was not able to bear weight and he had tenderness around the left hip joint. Rotations were very painful, and we can make out that there is a lytic lesion in the left proximal femur. This patient was advised to get an MRI scan done, but unfortunately he ignored it. And since the pain increased, he went ahead and got a new X-ray done, which clearly indicated that there is a pathological fracture now of the neck and the lesion has increased in size. At this stage, the orthopedic surgeon ordered an MRI scan, and it was reported to be either a giant cell tumor or a chondroblastoma, essentially a benign tumor. And these were the images that he had of the MRI, which indicated that almost the entire femur, head and neck is involved by the tumor on this MRI. A biopsy was done, which is the first step after we see an X-ray and MRI, and the biopsy was reported as a benign giant cell tumor by the pathologist. So the surgeon went ahead and did a curettage, fibula bone grafting and plating, which is essentially the recommended surgery for benign tumors. Unfortunately, this patient had persisting pain, and 2 months later, when the X-ray was done, it indicated that the entire femur head as well as the proximal femur was resorbed by the tumor, and the fibula graft was intact, but the plate had migrated proximally. And most importantly, it's not only the proximal femur now, but the disease has crossed the joint, and it now involves the acetabulum as well. So what was the disease which was limited to proximal femur now involves the acetabulum as well, because we have given it time to grow. The same slides and blocks which were originally reported as giant cell tumor were reported by another expert pathologist, and he concluded that this was a telangiectatic osteosarcoma right from the beginning. We know that telangiectatic osteosarcoma is a rare diagnosis, but unfortunately, it can present very similar to many other benign tumors as well, and it needs a lot of expertise to diagnose the malignant tumor. So we went ahead and did an extra-articular resection, because now the acetabulum as well as the proximal femur are involved, and we had to include all these scars in the incision, because all these scars indicated that the tumor has been contaminated in the skin and muscle as well. An extra-articular resection was done while sparing the femoral artery, vein, nerve as well as the sciatic nerve. But we could make out on the pre-op MRIs that the neurovascular bundle was away from the tumor, so we were able to dissect it out and save it. This is a resected specimen which we sent to the radiology department, and the radiograph indicated that the tumor was removed with good enough boundaries without any spillage. This is a patient now who 2 years later is walking with his own X-ray without any support, which indicates how far we have come in dealing with malignant tumors of the bone, and those tumors which otherwise would have required a hind quarter amputation or a hip disarticulation. But young patients, especially those who respond well to chemotherapy and those who are motivated enough to rehabilitate themselves, usually do well with these kind of major surgeries because of advances in surgery, anesthesia, as well as the rehabilitation techniques. So I would like to conclude by saying that orthopedic oncology is a relatively new branch of orthopedics, and it's evolving every single day. And as we know that bone tumors for some reason have increased in incidence, and our aim is to make sure that we do justice to every patient. And we should remember that 95% of all sarcomas, in 95% of all sarcomas, the limbs can be salvaged with good function, and about 85% of sarcoma patients go on to live a good life with good chemotherapy response. I would like to thank Dr. KJ Reddy sir, Dr. Sai Tarun Reddy, and the organizing team, including Dr. Raviteja Ruddaraju, for giving me this opportunity.
It was a wonderful presentation, Dr. Rajiv, and thank you for the elaborate talk. Do we have time for questions, sir, or should we go ahead with the live surgery? So, Dr. Rajiv, thank you so much. Because we are having a lack of time, we are going ahead with the live surgeries. Thank you.
Thank you so much.
Thank you, sir. That was a wonderful talk. Now we have Dr. Bhanu Prakash, sir, performing a live surgery, which is a diagnostic, arthroscopic, and meniscal repair. I request Dr. Gopinath Bandari, sir, and Dr. Praneeth, sir, to moderate the session.
Bhanu, sir, are we audible, sir? Bhanu, sir? Hello? Are we audible, sir?
Praneeth?
Sir.
Yeah, am I audible to you?
Yes, sir. Audible, sir.
Okay, okay. Good afternoon, everyone. Hello?
Yes, sir.
He is a 22 years old male patient had a pain in the right knee for last 2 months, had a twisting injury to the right knee 2 months back. On a clinical examination, he had a mild anti-laxity with a definite endpoint. I think it is a partial ACL tear. We'll go ahead and see how it is inside. And it is a Lachman's McMurray is positive for lateral meniscus. And MRI also shows like lateral meniscus tear, posterior hand tear, and MRI shows. And ACL is intact, it seems. So we go for the diagnosis arthroscopy. If needed, we'll see it how it is going on the meniscal tear, meniscal repair will be done, and ACL will assess and do it. Okay.
Can you demonstrate the Lachman test, sir?
Okay, sure.
After Tony.
Okay. Focus it here. You see this? Not much. The definite endpoint is there. Come this way. Come. Focus it here, camera. Light. See this.
Yes, sir. There's a definitive endpoint.
Definite endpoint is there. Even the anti-diet also not coming forwards much. And even the pivot shift also negative. So we do the diagnosis arthroscopy and reassess it.
Yes, sir.
Okay, right. Just I'll show you what are the portals and everything. Not marker pen. And this is your patella. This is the tibial tuberosity. And this is your patellar tendon. This is patella. So for diagnostic arthroscopy, have an anterior medial portal, anterolateral portal. For diagnostic arthroscopy, meniscal repair, there will be portal should be little low. And if you are suspecting for the, we're suspecting going for the anterior ACL tear, it will be little high.
Can you show us the joint line, sir?
This is the joint line. See, palpate it. And this is the joint line. This is joint line here. This is joint line here. And this is the patellar tendon. And we are suspecting for diagnostic arthroscopy, you should go little lateral, away from the patellar tendon. So we feel a soft spot. This is the joint line, little above. Feel a soft spot here. You'll feel it. So then go to mark it here. This is for the lateral portal. And middle portal should be somewhere here. For arthro ACL deconstruction, we will have vertical above and.
Banu, can you ask front camera? To only see zoom out and front camera. Camera from the front.
Yes.
So 90 degrees to each other so that we can. Yeah, that's better. That's better.
Yes. So this is the patellar tendon. This is the tibial tuberosity. This is the joint line. And this is our portals for the diagnostic and meniscal arthroscope, meniscal repair portals. And this will be our ACL reconstruction portals. Above and little medial. Now I'm going for the anterolateral portal. And this is, so I'm putting my thumb here so that I'll protect my meniscus, lateral meniscus. Wait. And the knife should be away from the patellar ACL. See. And you open the inside.
Zoom out a little. Yeah.
Camera. Nothing is there. Nothing is there. Inside, no effusion. No hematrosis. That indicates it is an old injury. Camera, please. Zoom. Water. No, it's not. No, here. Pump. Here this is.
Yes, sir.
Okay.
Focus it, Banu. It's not focused.
It is focused, sir, now. So this is the middle gutter. That is the first thing you do. Coming to the medial joint line, medial compartment. So this is look the medial meniscus looks good, and this will be our ACL. I'll go through it. I'll take a lateral medial portal. See medial portal. You can one way is you can see the light here.
We can't see.
The focus this
Show the
camera.
outside camera, not the monitor.
Not showing. Switch on.
Show the knee
Switch
joint.
it.
Can you have picture in picture?
Picture.
Picture in picture.
Huh?
Aravind, can you do picture in picture? Small one, big one. Outside, inside. Yeah, that's better. Okay.
Okay. So one way is to see the light here, so they can do a guide to how, where to put the portal, or else you can take a needle. The 18 number needle, I'm using it to guide our portal. See, she is coming here. The needle.
Your camera is moving too much, Banu. Keep it a little stable because it's yeah, that's good.
It's coming here. Okay, I'll take a little shaver. Shave that pad of fat which is obstructing my view. Fit. Okay. I'm taking this is my shaver.
So you're clearing your portal.
Clearing a portal. And your shaver sharp edge should be away from your vital structures, the meniscus and ACL. I'll clear the fat here also, this side also, so that my vision will be clear. Take it. Probe. First thing we check is the middle meniscus. So middle part is good. Shave, wash. And looks anterior horn also good.
Looks normal, yeah.
Intact. Looks normal.
Can you give a wash?
Giving. Later, once I keep the leg down, I will show the posterior horn of middle meniscus. And this is ACL. Our ACL
looks okay.
Looks okay. And this is our PCL. I'm hooking it. This is also looks okay.
So, is there any single bundle tear of the ACL, sir?
Just I'll check it, Pranit, once.
Because the PCL is visible more clearly.
See, PCL is visible. Okay. Here looks like
show us the femoral attachment. Turn the light 90 degrees and show the femoral attachment. Don't move the camera.
Yes. This is the femoral attachment, sir. That is, see this.
Yeah, what Pranit is saying, a little lax.
Little lax it is there because this some fibers of the posterior lateral fibers are tear, I think. But overall it is stable.
Looks intact, yeah.
Looks intact, stable. As Pranit said rightly, as well there should be some fat layer should be there in between. Some fibers are torn, but it is clinically and also it's stable, Pranit. Yeah. And as you said, PCL is visible clearly. There's some fiber that may be. Those are torn fibers, but it's intact. And I'll show you the medial meniscus posterior hand. Take it, Jaram. Which valgus and valgus and action rotation. So you go here. Action rotation. Right. See, I am hooking the posterior horn male meniscus. Hooking it. I think not visible properly. Keep it down. Keep it. It come this way. Come this way.
That looks good. It's not opening too much. That means ACL also not very lax.
Not very relaxed. See, I'm hooking the extension valgus. See, this is a intact, sir. That is intact. Posterior intact. So now go to the lateral meniscus, which was our concern. For doing lateral meniscus, you'll do it in a figure of 4.
That picture in small one, zoom out. Ask the Aravind, can you zoom out? We don't need close view. You want to see entire leg out more. Yeah, that's better. Okay.
There is a lateral meniscal tear there, sir. Complete. I think flipped out.
Yeah.
Punch.
Yeah, if we clear the fat, yes. Yeah.
Sir, what are you planning? Repair or the partial?
Just let me see once, please, whether I can repair or it looks like chronic tear and everything is fimbriated. Whether repairable or not, I will see it. But let me clear.
Sir, what is the duration of the tear, sir? From how many days the patient is suffering?
Patient is saying the history of 3 months only, but doesn't look like 3 months. It may be more than 3 months.
Yes, there is a lot of fraying in the.
Lot of fraying. Lot of fraying is there. He must have had a old injury also.
Yes, sir. What is the age of the patient?
23 years.
Yeah, sir. Patient has got any instability or only the pain?
No instability. I demonstrated also. Anti-Ryan enlargement tests are negative.
Yeah, yes. So no instability means no need of ACL reconstruction.
ACL, no. ACL, no way.
Yes. Okay.
Not at all. So I'm cleaning the fat, the lateral side also.
Try to reduce it, Banu, then you'll have a better picture.
So we'll see.
Okay, who can reduce it?
I'll clear it once. Somebody has to hold it here also. Press the knee down. Yes. Wait 2 minutes. It looks, yes. I got it here.
Extend a little more.
Extend.
Lift the foot up. Jairam, can you lift the leg up? Yes. Okay. Now it will look.
I think
Probably that's all shredded.
Shredded, sir.
You can so shave it off. Shave it off that part, then you can decide. Shave that part. Looks like chronic tear.
Chronic tear, sir. I think it is.
Shave that one out. Put the shaver in the middle. Yeah, good.
Sir, as we all know, whether we have to repair or do partial meniscectomy, it depends upon the duration of the tear, tissue quality. Where is the tear? Whether it's in the red zone or the white zone. And
basically, our intent should be to retain the meniscus as long as possible. Depends on the where, as you said, where it is exact red zone, white zone, or white zone. But it may be whether it is healed or not.
And the most important is tissue quality. If the tissue quality is not good, even if you do repair, it will not hold the stitches.
Not hold the stitches.
Yeah, shave that part as well.
Probe. Probe. Coming here. This part I'll shave it.
Yeah, shave that part. That looks very
Very degenerated. I think
that part is okay.
that part is this
Not
is
coming
not
inside. Yeah.
this is not coming inside. Only this part.
Shave that one out.
Root is fine, sir.
Pranith?
Root is fine, sir.
Root I not seen. The posterior root looks okay, and the anterior have to see it. Posterior root looks okay. Here is the na. This root okay, looks good.
Yeah, shave that part as well. And that's all regenerative.
Maybe again it goes there, it will become, that is ACL, so you can't go there. So this part here you have to shave it. I'll shave this will clearly.
Put the shaver away from ACL, then
Yes.
go in the gap. Right size is good enough.
Probe. So this is the remaining meniscus is stable. Here it is. This part is there. Now what to do? I think this is not repairable.
Yes, sir. Not
Yeah, I
repairable.
think take it out. Take it out.
Not repairable. I'll take a punch and clear it off.
Sure. I think probably Ravi, we can. So he's going to take that one out. Probably we can go ahead have lunch.
I'll take over this. Okay.
Tell him.
I'll decompress it. Little.
Sir, articular cartilage is okay, na sir?
Looks okay. Articular cartilage is very good. Seriously.
Because nowadays we are seeing many young patients with severe cartilage damage.
See, now it is, this is a femoral condyle is okay. Tibia looks good. Middle compartment you have seen
Sir,
already.
Banu, sir.
Yes, Karthik.
By the time you clear, we are going with the
Sure.
Dr. Gopinath, sir. Once you clear, we'll be on.
I'll get back to you. Thank you.
Thank you, sir.
My God. Shivaram.
కేబుల్ ఎక్స్టెన్షన్ లేదా కేబుల్ ఎక్స్టెన్షన్ ఉంటుంది కదా జూమ్ కి కూడా
Yes, Itla press చేస్తే little bit clear. See this how it is now. పంచ్ బాగుంది, పంచ్ బాగుంది మన దగ్గర కరెక్ట్గా వస్తుంది. చేస్తే కట్ అవుతుంది. చేసేటప్పుడు వాష్ చేయాలి ఎవరన్నది. అంతే. That is clear.
So, Arvind, can you disconnect OT? We will have lectures.
Section
Thank you, Banu. That was wonderful demonstration. Big applause to him.
Thank you, Dr. Banu, sir. We'll now continue with our talks. Now we have Dr. Gopinath Bandari from Apollo, who is the consultant hand, wrist and microsurgeon. He's going to give a talk on understanding and management of wrist arthritis. Please, Dr. Gopinath, sir, come and share your views on that. Thank you.
First of all, good afternoon to all the delegates and all the dignitaries. And I would like to thank KJ Reddy sir for giving this opportunity and all the team from SVS. So we are giving this talk on the occasion of World Arthritis Day, and that's the reason, being a hand surgeon, I've choose to give some brief insight into management of wrist arthritis. And wrist being such a very complicated joint, unlike the major joints of the body, it's very difficult to understand the anatomy of the joint and also to even read the X-ray. So I actually wanted to put the title as Decoding the Da Vinci Code and Understanding and Managing Wrist Arthritis. So if you see a Da Vinci painting, it's very complex and there's so many multitude of components involved in it, and we have to decode all the components out of it, and then only we'll be able to understand what exactly is happening and what is the component involved in it. So unless you know the clear anatomy of the wrist joint, the bones involved, the joints involved, and the number of ligaments involved, we cannot read the wrist X-ray, and then we cannot give them a perfect treatment. So as we say, the rest management of any joint arthritis is basically rest, ice, medication, splinting, and multitude of surgical options which we have. But wrist arthritis is not that simple. There are many other things involved, basically starting from anatomy to the management. So my talk flow would be firstly understanding wrist biomechanics, because that would be the one which would guide us to the treatment. I would briefly take you through that, and of course understanding the stages of wrist arthritis and then how to go ahead with that. So wrist arthritis stages and the management will go simultaneously. Biomechanics I will start early. So if we see the complex joints, the large joints of the body like the shoulder, knee and hip, all of us have clearly understood how these joints work, the structures involved, and this management easy. It's a complicated affair. There are 8 bones in the carpus. There are multitude of ligaments comprising of 8 intrinsic ligaments within the joint, 9 extrinsic ligaments outside the joint, and many tendons passing through the joint volarly and dorsally, and totally comprising of 14 joints. So if we are dealing wrist, it is not one joint which we are dealing, we are dealing almost 14 joints. So many ligaments on the volar and the dorsal aspects. And to complicate things even more, each bone behaves in its own way. And these are tiny little bones with narrow joint spaces and many rotational spaces on the lunate. Scaphoid tends to exert its force on the lunate by.
Can we have Shiva Reddy sir to join us as a moderator for session, please?
Thank you. So different types of bone exert different types of pressures on the lunate, which is the central piece of bone. The scaphoid always tries to flex the lunate, whereas triquetrum tries to extend the lunate. So two different bone act in two different directions and keep changing the direction of forces. And when any trauma happens, be it a scaphoid fracture or be it a scapholunate ligament injury or any other thing, these are the forces which keep changing, and that's the biomechanics also keeps changing. So if we tell in a very funny way, we can consider lunate as the very promiscuous lady who is going around with these two strong men, the scaphoid and the triquetrum. Whenever there is any pathology in the scaphoid, lunate tries to go with the triquetrum, which is stronger. Whenever there is any pathology in the triquetrum, lunate tries to go with the scaphoid because scaphoid is now stronger. Similarly, when there is a scaphoid fracture or a scapholunate ligament disruption, then lunate automatically moves and goes into extension along with the triquetrum. And similarly, when there is a triquetrolunate ligament tear or a triquetral fracture, scaphoid automatically moves with the lunate automatically moves with the scaphoid and goes into flexion. So that is how the funny things happens. And coming to wrist joint, how it fails, how the ligaments disrupt, and how the arthritis sets in. All this also happens in a particular format and is described by Mayfield. Mayfield actually started this description in the form of progressive perilunate instability. And this whole progressive perilunate instability concept is now adapted by in the form of wrist joint failure and also in the form of wrist ligament disruption. So even when the wrist ligaments get disrupted, the same pattern of progression goes on in the form of Mayfield. So the progression starts from the scapholunate joint, as you see here, that's the number one stage of the Mayfield, and the progression goes all around the capitolunate joint. That is the stage 2. And when it progresses, the stage 3 comes to the triquetrolunate joint, and then the stage 4 is the finally radiolunate joint. This is the way the perilunate instability progresses. But after a lot of consensus with the many arthritic changes which we are seeing, we have come, the scientists have come to a conclusion that even when the arthritis happens, the arthritis also progresses in the same way, be it a snack wrist or a slack wrist or advanced collapse, whatever sort of an advanced collapse in a wrist progresses in the same way, and it is staged in the same pattern. So again, in Mayfield disruption also, we can see there are greater arc injuries, there are lesser arc injuries. Greater arc injuries constitute with the radial styloid fracture, giving to transcaphoid, transcapitate fractures and a progressive perilunate instability. And lesser arc injuries go through mostly ligamentous structures. So coming to types of the wrist arthritis which we have, most common thing which we see is the inflammatory arthritis commonly seen in rheumatoid arthritis or connective tissue disorders or post-traumatic disorders, which are very late to see. And the most advanced one is the snack wrist and the slack wrist. We'll discuss on it later. And degenerative arthritis is very uncommon if we come to wrist joints, because degenerative in India we commonly see in the shoulders or knees and hips. And infective arthritis, again, a very rare entity. It can be probably septic, very rarely, or commonly we see tubercular. And in tubercular, it can be very erosive sort of arthritis. So inflammatory arthritis, if we see it, this sort of a picture is very common in rheumatoid arthritis, wherein you can clearly see that is there is a lot of erosion, subluxation in the wrist joints, and subluxation and involvement of all the metacarpal and phalangeal joints and the PIP joints. So the most common management we do for wrist arthritis is the wrist fusion. This is the most commonly done even in our setup also. And that gives a good stability, painless joint and a stable joint. and we use a wave plate, or if the wave plate is not available, we can also use a simple DCP, which we can bend over 20 degrees to give a functional extension. The advances in the wrist arthritis is the total wrist arthroplasty, where we can remove both the offending joints and then give prosthesis which can give a painless and a good stable joint. Coming to post-traumatic wrist arthritis, there are two components involved, that is the snack wrist and that is the slack wrist. These are the most advanced forms of post-traumatic arthritis. Coming to snack wrist, this is followed by a neglected scaphoid non-union. With scaphoid fractures which go into chronic non-union, which are not treated properly, not casted or not operated properly, gradually arthritis sets in because of the non-union. This happens predominantly in unstable fractures. Stable fractures, however long they are untreated, they do not go into snack. Only unstable fractures go into the snack sort of components. Watson has given the staging for this, and also this follows the Mayfield progression, which I have showed earlier. The stage 1, the arthritis sets in at the radiocarpal joint. Stage 2, radioscaphoid joint. Stage 2, the radioscaphoid and the scaphocapitate joint is involved. And stage 3, along with the radioscaphocapitate, the lunate also is involved, and the radiolunar joints are also involved. That is, stage 3 is the snack wrist. Stage 4 is completely arthritic, that is not called snack. So for snack wrist, the better the treatment which we usually do is the 4-corner fusion for stage 3. If it is below stage 3, we can do something like a proximal row carpectomy, which I very commonly do. For a 4-corner fusion, we remove the offending bone, that is the scaphoid and both its non-union fragment, and then fuse the 4 other carpals using a spiderweb plate or Herbert screws or K-wires, depending on the affordability of patients, and then we can prevent further progression of the arthritis. This gives a very stable and a painless and good range of motion to the patient. Coming to scapholunate advanced collapse, again, this also progresses in the same pattern as the Mayfield, and Watson has given the similar classification which we have discussed earlier. And the best treatment which I do regularly for such cases is just remove the offending entire proximal row. That would give a very painless joint and good range of motion. So by removing the proximal row, we give a new articulation. The capitate comes and sits with the in the lunate fossa, thereby giving range of motion. So by removing the entire carpus, the forces are also lessened on the carpus. The forces crossing the radiocarpal joint are also reduced so that the pain comes down. So this is a proximal row carpectomy. I keep doing this regularly for all my keen box, stage 3 keen box especially. And next is I wanted to add a little about wrist arthroscopy for early stages, because this is advanced arthritis. We do not do wrist arthroscopy, but for the early stages of wrist arthritis, we can do synovectomy and give them a significant pain relief. And I thank the organizers and KJ Reddy sir for giving me this opportunity. Thank you.
Thanks, Gopi. That's a wonderful talk. Any questions?
Yes, sir.
I am Dr. Chavan Jayakrishna, Professor of Orthopaedics, SUS Medical College, Magadar.
Yes.
Dr. Gopinath. So in case of carpal instability, it is the only scapholunate. Fusion is enough. You need not necessarily go for proximal row carpectomy and all those things.
Yes, sir.
So what is your opinion on?
If it is early instability, then even scapholunate fusion is not needed. We can address it with ligament repair. And in chronic cases, we can also do it with ligament reconstruction. We do have good procedures for that. But when the arthritis sets in those scenarios, limited carpal fusions do have a good result. But if we are doing that, I prefer to arthrodesis the scapholunate along with the radius, and then the movement sets in at the mid-carpal joints. So that has more promising results compared to only scapholunate fusion. Because if we do only scapholunate fusion, what happens is trichotrum will be trying to flex the entire lunate with the scaphoid now. Then the biomechanics will be altered, and that sets in a lot of pain, and early arthritis would be done. So if we are fusing, it is better to fuse the scaphoid and lunate to the radius so that the entire proximal row movement is fused.
But you are restricting the range of movements. The functional hand is different from non-functional hand.
Yes,
That
sir.
should be categorized.
Yes, sir. But problem which comes here is in the aim of function, we are giving him something like an early arthritis. So by fusion, though we are restricting the range of motion, he will have a solid hand, especially laborers and all such sort of people, they will be doing well. And instead of doing such sort of an arthrodesis that needs a lot of immobilization, metal inside, instead of doing that, if you want range of motion, proximal row carpectomy can do all the functions which we both want now. So it gives range of motion, it avoids immobilization, it avoids long-term immobilization, metal inside, all the things are avoided. Just remove the offending things and everything is clear. That too when there is no signs of arthritis, and when you open and see that the radiocarpal joints, capitate also has to be good. If the capitate also has some fibrillations or lot of loss of cartilage, again we can't do that.
What about this dequarins injury?
Sorry, sir?
Dequarins injury, transscaphoid perilunate injury. So what is the mode of management, plan of management?
Again, if it is acute or chronic. Acute, directly we reduce openly. Close reduction, Tavernier's maneuver, usually we don't get it because of the swelling and all those things, but we can try that. But I prefer open because even studies have shown that open has better results compared to close, because restoring the anatomy is better with open in greater arc injuries, the one you said. So I open, and majority of the times I use Herbert screw for the scaphoid. And recently I used Herbert screw for one transcapitate thing also. And rest of the ligaments, I do not repair initially. I just put some pins. That is enough. Once you close the capsule and wait for 6 weeks, the ligaments will heal themselves without any issue. But the problem comes in chronic injuries. I don't know if you're asking about chronic injuries. In chronic injuries, usually the cartilage will be denuded, eroded, and there is no point in trying to reduce the scaphoid. So in that scenarios, depending on the cartilage involvement, we have to take an intraoperative call whether we are going with a limited fusion or a proximal row carpectomy or a 4-corner fusion. The decision has to be intraoperative.
Where do you indicate this 4-point fixation or fusion?
Indication is when SNAC 1 and 2 4-corner fusion can be done. When it comes to SNAC 3, that means there is some involvement of radiocarpal joint also. In those cases, SNAC 4-corner fusion cannot be done, because even if we fuse those, lunate and radiolunate arthritis will be already existing. So there is no point in fixing the 4 corners. Only for stage 1 and 2, where the radiolunate joint is still non-arthritic, when the radiolunate articular cartilage is good, only those cases we have to do a 4-corner fusion.
Okay, thank you very much.
Thank you, sir.
Thank you, Gopi.
Okay, now we will go back to the theater.
Thank you so much.
We would like to show, after post-meniscectomy, they would like to show the meniscus, and we'll get back to the podium to finish the talk.
Hello, Banu sir.
Praneeth. Can you hear me, Praneeth?
Yes, sir.
That was like a subtotal meniscectomy almost, but 90% of meniscus are resolved actually. We didn't do anything. So this is completely meniscal free. Probably he needs, if at all he wanted meniscal replacement.
Okay, sir.
See, this is nothing. There was nothing. We did it. Almost 90% meniscus was resolved before we put a scope. After this, posteriorly some meniscus was there. So I did this one, reshaped, decompression reshaping was done. I'll show you this one. See, this is.
That's excellent, Banu. Well done.
And other thing, there are nothing, no meniscus, sir, actually. Our 90% meniscus was gone before we put the scope only.
Yeah. Very good. Very good.
Thank you, sir. Thank you very much.
Very good. Very good. So all of you come to lunch on entire OT team. Come to lunch near Auditorium. Dr. Jairam, bring all of them to the lunch. Okay.
Thank you for a wonderful talk, Gopinath sir. I would like to invite Dr. Raviteja Rudraraju, consultant knee surgeon and sports surgeon at Apollo Hospitals, to deliver an insightful talk on advances in knee arthritis management.
Good afternoon. I'm completing the last talk of the session. So we have heard enough topics regarding shoulder, wrist, hip. So I would like to close the CME with knee preservation, although it's not directly related to arthritis. But if you don't address some of the issues related to the knee, people end up with knee arthritis. So I would like to cover a couple of topics that how can we manage so that the patients will not end up in knee arthritis. So we see when we talk about cartilage repair and restoration, we have got some palliative techniques, marrow stimulation, and restorative techniques. So when we do chondroplasty, that's a palliative technique. We try to preserve the cartilage by just shaving off it. And then in terms of simulation, we try to kind of do microfracture subchondral drilling. And in restorative techniques, we do microfracture plus techniques, autologous chondrocyte implantation, oats, and osteochondral allografts. So when we talk about cartilage restoration, we talk about cells, scaffolds, and bioactive substances. And these all come under tissue engineering. So we can mix interchangeably and try to preserve the cartilage. If you see in the bird's eye view, when we talk about cartilage defects, we call it focal cartilage defects or osteochondral defects. They can be small or they can be large. When it is less than 2 to 3 centimeters square, it's small. And if it's more than 3, it's large. So when you have only chondral defects only of small size, we prefer doing marrow stimulation using scaffolds or maybe with juvenile particulate allograft. And when we talk about osteochondral defects, small ones, we talk about oats and mosaic plasty. And in case of large defects of more than 3 centimeters square, if you do chondral only, then we do ACI, scaffolds, and again, juvenile particulate allograft. And if it's an osteochondral defect, then we try to do an ACI with bone graft. Firstly, talking about the cartilage repair in terms of microfracture, usually if you do that, we try to restore it back with the fibrocartilage, usually type 1 collagen, but it has got rapid failure. But it is preferred because of its single stage, it's inexpensive, and it can be done arthroscopically. But the results are poor, and it cannot be addressed in large bone defects. And in case of durability, it has got 2.5% failure rate in the first 2 years and around 6 to 38% in the 10 years. And up to 48% of osteoarthritic patients might end up with osteoarthritis in the 15-year follow-up post microstimulation. So some of the technical pearls, it's always important to remove the underlying calcified cartilage and consider drilling within conical awl rather than a drill. Because when you drill it, it burns the cartilage and the tissues, and that will not prefer forming the cartilage. In case of microfracture plus techniques, it's something called as joint rep. We try to inject bioscaffold along with microfracture to stabilize the clot and to form the fibrocartilage. Now talking about the autologous chondrocyte implantation. So it's trying to kind of restore the cartilage by taking some of the cells, taking to a lab, regrowing them and reintroducing them back to the defect. So it can be done in large defects. And one of the limitations is that you should have a full thickness defect and it needs 2-stage procedure. So there are different generations. First generation where we use just a periosteal patch from his own body. And in the second generation, we use chondrocytes injected under the patch, and the patch is collagen membrane. In the third generation, we use porcine membrane, which are embedded by the cells. And in the fourth generation, which we call CAR-T-grow, wherein we grow the cells in the lab and stabilize with a gel. So one of the famous, most commonly done technique is ACI, which is matrix-associated autologous chondrocyte implantation. So as I just mentioned, we just harvest the cells, grow it, and then put it back into the defect and close it with a patch. And again, the limitations are 2-stage procedure, and you cannot ask the patient to bear weight immediately. And ACI when it gets repaired, you often see hyaline cartilage, and that is one of the biggest benefits of this procedure. And some of the technical pearls is that you can't do it in an uncontained lesion, although you can prefer in some cases where they have partial uncontained lesions. And you should always make sure that the graft is stable. So this is one of our cases done by Dr. KJ Reddy sir. So whenever someone has a chondral defect, we should always think of alignment. If there is a varus or a valgus alignment, it's important to correct the alignment as well as do the procedure. So CartiGrow, which is a 4th generation ACI, it has got 2 steps. One is tissue harvesting and then implantation. Basically, you harvest it from the non-weight bearing area and then put it back into the defect site. You prepare the defect site so that you make sure that there are 90-degree walls, and then you put holes there and then pour some saline and then inject the cells and stabilize with the gel. And followed by physiotherapy, of course, non-weight bearing for the first few weeks, followed by partial weight bearing, strengthening, and getting back to sport. Some of our cases wherein we have done CartiGrow on patella, we have freshened the defect and made sure the defect is clean. And we've made a hole on the cartilage defect and placed back the cells along with gel to stabilize the defect. And one of our patients who had this procedure on the medial femoral condyle, it's a large defect, more than 3 centimeters, made sure that we cleaned it and we applied the cells and stabilized with the gel. And this is how it looks post procedure. And it can also be used in full thickness defects, wherein we use the bone graft and the chondral implant. It's called the sandwich technique. And definitely the patients who have underwent these procedures have got great outcomes. If you can see there, IKDC scores pre-op were 26 and followed by post-op at 6 months and 1 year were more than 50. This is post 2 years follow-up, wherein you can clearly see the hyaline cartilage restored after the procedure. And this is arthroscopy after 1 year, just to revisit to make sure how's the defect. And it has been impressive to see that the defect is completely cured and patient is back to normal. And the other technique that we do is called OATS, which is osteochondral autograft transfer system from Arthritis, and from Smith & Nephew call it mosaic plasty. So it's done to replace the defect by normal autologous cartilage or bone plugs from the non-weight bearing areas. You try to harvest these plugs from the non-weight bearing areas and try to put it back into the defect site in the weight bearing area. It is a single stage and it's not really expensive. And one of the limitations of this procedure is that it creates a donor site morbidity. And definitely the ideal site to harvest the graft is from the proximal to the medial sulcus terminalis. And when you compare microfracture versus ACI, you can clearly see that these kind of procedures have got better hyaline cartilage than other procedures. So it basically replaces the defect with live chondrocytes in mature matrix with underlying bone. Definitely benefits are it can be addressed also in the large defects, as well as an excellent option for patients who underwent ACI, microfracture, and mosaic plasty and have not had a successful outcome. There's a risk of infection and risk of immunogenicity, but the risk is comparatively less in order to prefer the procedure. The outcomes are really good. In 5 years survival rate was 95%, and at 25 year it was almost 60%. And most of the patients, particularly the sports people who have these injuries, can get them back to the sport. And looking at the paper from Aaron et al., they have looked at patients who have undergone different procedures like OATS, osteochondral allografts, ACI, and microfracture. You can clearly see OATS has been more preferred technique because 94% of patients have been returned back to the sport. And the last one is a microfracture, wherein only 60% of patients had a better outcome. So if you look at the COO scores, there was one study done by the same group. At 1 year, OATS was more preferred than microfracture and ACI. But at 5 year follow-up, OATS and microfracture performed better than autologous chondrocyte implantation. In a 10-year follow-up study done by Gudas et al., they looked at the randomized trial of osteochondral autologous transplant versus microfracture. in 60 athletes, and they have seen that oats significantly better performed than microfracture, and 14% of oats had failure compared to 38% of microfracture patients. So the conclusion from this study was that return to sports was higher in patients underwent oats procedure. There was another systematic review done on autogenous chondrocytic transplant outcomes, and they compared oats microfracture versus ACI, and they have looked at 1 year follow-up. Definitely oats versus microfracture, they have seen oats performing better with better clinical outcomes and higher return to sports. And oats versus ACI, there were no differences, and better results were seen in smaller lesions less than 2 centimeters. And one prospective comparative trial between autologous chondrocyte implantation and osteochondral cylinder transplantation in cartilage repair. They've looked at prospective randomized control in 2-year follow-up. In terms of histopathology, they've looked at more fibrocartilage was formed in ACI and more hyaline cartilage was formed in oats procedure. But there was slow recovery in patients who underwent autologous chondrocyte implantation in more than 10 to 12 months. And clinical outcomes were more superior in patients underwent mosaicplasty. So just to conclude my talk, this is again a summary slide. How do you manage cartilage injuries, and why should it be managed well? If you don't manage these cartilage injuries, patient will end up having arthritis down the line. So first you need to do a scopy and then see what's the defect size. If it's less than 2 centimeters, then you can prefer doing marrow stimulation with or without biologics. And if it's chondral or osteochondral lesion, maybe an autochondral allograft is one of the best options. But in patients having larger defects of more than 2 to 3 centimeters size, osteochondral allograft as well as scaffold with biological resurfacing is a preferred option. And 3 important things that are very, very important to have a successful outcomes for these procedures are: the patient should be examined for the malalignment. If you've got a malalignment of the knee and you do this procedure, they're bound to fail because of irregular or inappropriate weight bearing. So whenever that is there, so you have to plan a high tibial osteotomy, a corrective osteotomy along with this procedure so that these procedures won't fail. Similarly, in case of meniscal deficiency, it's also important to consider transplantation. And also in patients who have got ligament instability such as ACL, PCL, these procedures are not really going to have a great outcomes unless you reconstruct the ligaments and give the better stability to the knee. Thank you once again for this wonderful opportunity. I would like to thank Dr. KJ Reddy sir for giving us this great opportunity and helping us to take this forward. Thank you once again.
Thank you, sir. That was an insightful talk. I thank Dr. Karthik sir, Dr. Pranit sir, and Dr. Shiva Reddy sir for moderating the session. Now I request Dr. Pranit sir for a vote of thanks.
Good afternoon, everyone. I deem it an honor and privilege to propose vote of thanks. First of all, I take this opportunity to thank our chief guest, Dr. Krishna Reddy Garu, Dr. KJ Reddy sir, our organizing chairman, and Dr. Ram Reddy Garu. I also thank the principal, vice principal, and other professors of SVS Medical College who has joined us today. And I thank our senior colleagues who are wonderful speakers for joining the live surgery session and delivering the talks and enlightening us today. I thank such a wonderful audience who has joined us in the auditorium and in the OrthoTV and making this program a good success. I also thank I take the opportunity to thank the OT staff who are behind the stage and major in this program, our sponsors, the ground staff, and also the audio-visual team. A special mention to the electronic and print media for covering our program. Thank you. I forgot to mention the implant company, our debut Johnson & Johnson, who has sponsored the implants. Thank you.
Yeah, and the Regrow team, Regrow, who sponsored the OrthoTV.
Yeah.
And thank you. Thank you, everyone.
Thank you.
We would like everyone to please join us for lunch. It is arranged in the indoor sports stadium. Thank you.